Now everybody is inside the conference hall. Here, people are sitting. Just 5 minutes more to start the conference. All the arrangements are already done. This is the counter for mementos. And here the speakers have come, being photographs. Delegates are sitting inside the auditorium.
सर सर यहाँ सर
आ जाओ आ जाओ आ जाओ, बैठ जाओ.
कांबळे सर या सर, तुम्ही दोघे येता, हो या लवकर.
आ जाओ आ जाओ.
चल चल लवकर लवकर लवकर. मॅडमला पण बोलवा.
जिकेट आहे.
हा जिकेट आहे. जिकेट आहे.
नाही दुपारी. अरे मॅच दुपारी आहे, 1च्या नंतर आहे.
अरे जल्दी लो यार.
किती वेळ लेक्चर संपला.
फ्लॅश नाही.
थँक्यू थँक्यू.
बैठो बैठो बैठो.
Hello, good morning. Good morning, everyone. This year we are going to have a quiz at the start of the program. Hello.
Hello sir.
This year we are going to have a quiz for us in the start of the program. We just have to answer from your six only. Who is the main hero in Mdmpa?
મહેતા પેશન્ટ હતો અને
You
બાજુમાં
can answer from your six
અરે
only.
પાંડે તમે લઈ લીધું પછી જગા કે
મારી જગ્યા.
આજે તમારી જગા નથી
Thank you so much for listening to the program. Good morning, शुभ प्रभात. महफिल को खूबसूरत बनाने थोड़ी सी हमारी मदद कीजिए. अनजान बनकर के मायूस न बैठिए, खुलकर मुस्कुराइए और प्रोग्राम का आनंद लीजिए. Thank you so much for everyone for coming here. I myself, Dr. Vijay Singh, proud to be the Honorable Secretary of the biggest regional association of more than 1,500 medical professionals in Mumbai. I wholeheartedly welcome this great gathering at the 33rd annual program conference of Mdmpa at this 5-star venue, beautiful hotel Taj Sandal. I follow in the line of remarkable leaders of this association and I resolve to build upon their legacy. The annual conference of Mdmpa not only allows us to meet, greet and eat, but also provides a unique platform for exchange of ideas and opportunities. As per our tagline, exceed expectations every time. Please put your hands together. I request everyone to stand for the national anthem.
पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे, तव शुभ आशीष मांगे, गाहे तव जय गाथा, जन गण मंगल दायक जय हे भारत भाग्य विधाता, जय हे जय हे जय हे जय 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 हे।
भारत माता की
जय।
Thank you so much everyone. Now we will start our scientific session, for which I welcome our this master of ceremony. First of all, Dr. Rajesh Gopani sir. और ही just two lines की ताबीज से होते हैं कुछ लोग गले से लगते ही सुकून सा मिलता है. Thank you. वाह वाह वाह. These are guru and mentor. You have been known for his scientific knowledge, humor, and knowledgeable nature. He is practicing general physician at Mahi since last 35 years. Please welcome sir. Thank you. Another one is the most hardworking guy of Mdmpa, ever am Dr. Nasim sir. He is practicing general practitioner at Dharavi since last 22 years. I welcome both of you. Please welcome on the dais and I hand over the dais to you. Thank you.
Hello and welcome everybody. I am Dr. Rajesh Gopani, your MOC for the 14th consecutive year. And accompanying me is this young guy, Dr. Nasim Khan, our Vice President Scientific, who has been practicing in Dharavi for last 25 years. नाम इसका नासिम है, मगर आज स्टेज पे फायर करने वाला है ड्यूअल सेट की तरह. No customary sentences like thanks for coming on a Sunday morning, such a big crowd, ये सब नहीं बोलेंगे because we know that Mdmpa is known for such a big crowd. And now we are ready for the first session of the day. And I invite, as usual, our opening batsman. This young guy, he plays with blood. Blood is his toy. By finding diagnosis from it, he gets joy. Please welcome the handsome Koi Boy.
Wow.
The Koi Boy amongst us from Angeles, Dr. Ajay Farke sir.
Now I would like to call upon the dais our chairperson for this session, Dr. Ashish Shah sir and Dr. Law Pashnikar sir. Where is the law? Yeah. Dr. Ashish Shah is a senior physician in Dharavi and also past president of Mdmpa. He is the executive director of Reach Hair and Scalp Clinic. And to accompany him, Dr. Law Pashnikar is a dedicated and skilled dentist with experience in providing high quality dental care. He is practicing since last 4 years in Dharavi. He is the leading practitioner, leading dentist in Dharavi. Please welcome them.
Over to you, Dr.
Thank you. Thank you. Thank you.
Sir, sir.
Thank you, Dr. Gopani. Thank you, Dr. Nasim Bhai, for your warm welcome for us. Now, to introduce Dr. Ajay Farke would be like a formality, but as my duty, I'll complete the formalities. Dr. Ajay Farke is a renowned consultant pathologist. He has completed his MD in pathology from St. G.S. Medical College, AIM Hospital. He is the head of Agilis Diagnostic, Dr. Farke Labs. He has special interest in molecular diagnostic, infertility, and flow cytometry. Dr. Ajay believes in using the right test at the right time, and that education regarding tests is crucial for appropriate medical care, and is a strong proponent of medical training. Over to Dr. Ajay Farke, and your topic would be clinical applications of diagnostics test.
Thank you. Thanks for this organization for inviting me. I think it's been over 5 years now since I've been speaking. One test we all have to do is to find out how Dr. Gopani looks so young.
Thank you, sir.
Sir, really.
So again, I'll start with the lecture topic. So today again we'll be taking clinical cases. Is my voice audible? Yes. Yeah. Okay. case actually is a 52-year-old male patient who has been complaining of low-grade fever since the last 6 weeks. Now this patient had come to the practitioner and he has fever on and off around 99 to 100. It is not cyclical, but it comes and goes during the day. But his major complaint is actually severe generalized body ache, mild joint pain and fatigue. Somebody had actually given him a course of antibiotics and that did not really help. Now, a routine panel of investigations was run for this patient. Most of the routine investigations were absolutely normal, including the chest X-ray, urine routine, but the only thing which was abnormal was a ESR which was 55 mm per hour. Now, this patient actually resided in an area which had a high incidence of tuberculosis, so the sputum was taken for gene expert, which was again clear. An IGRA test was done, which was negative. Because of joint pain and generalized weakness, an ANA test was also carried out, which was again negative. So the diagnosis was not yet clear with the panel of routine investigations. Now, there are multiple causes of TO with a high ASR value. The commonest, of course, would be tuberculosis and malignancy, but also because there was joint pain, leptospirosis, chikungunya, dengue, etc. were also ruled out. Endocarditis was ruled out with a 2D echo which was normal and autoimmune workup was negative. The blood culture was carried out, again that came negative. So there was still no real understanding of why this joint pain was there because autoimmune disease was ruled out and the patient still had the symptoms. Now, on further history taking, it was found that this patient actually lives on a farm and he has a profession of collecting basically livestock. And the issue is that people consumption of unpasteurized dairy products for some time, for many years actually. So now, of course, we all know that the unpasteurized milk, one of the commonest infections is zoonotic infection called brucella. Now, for brucellosis, why I am taking this case? Because it is a great indicator. We've seen many cases of brucellosis which present like autoimmune disease, which present like tuberculosis, which present like different illnesses. And most of the times, the investigations which are done don't actually give the diagnosis. Now, why is this? Because brucellosis is a short actually circulates in the blood for a few weeks. That has to be done, and then that's the only time the blood culture will become positive. After a few weeks, if you do the blood culture, then there are high chances the blood culture will become negative. And in that time, only the serology is there. So this patient, it had been about, by the time this test was done, it was almost 3 months. So in this patient, luckily we were able to get high brucella IgM titers as well as IgG titers which were weak. That's actually negative and PCR test also was negative. So we had a provisional diagnosis of brucella IgM IgG for the antibiotics. And why I am also stressing on this is because the blood culture also only 60% sensitive and it was negative. The advantage of serology is that even if the IgG becomes negative, before then 3 months have passed, and there are chances that the IgG can become positive. So it can give you a relatively fast brucella infection. So as you all know that there are multiple stages in brucellosis, but people know the condition of chronic brucellosis actually how they present clinically. So this was somewhere between acute and intermediate brucellosis. Then the patient started oxycycline and rifampicin, and the main thing in brucellosis is that with the follow-up serology, so IgG titers, IgM titers are used to monitor the illness as well. So if the titers are falling, the illness is rather the treatment is working, and if it is not IgM titers not falling, then we need to look into the treatment again. And we will also need pain relief for joint symptoms and other complications to monitor. But for brucellosis, we need to have it's a broad differential diagnosis because we don't really think of brucellosis in the first group, but we have seen quite a few cases of this. So lifestyle history and lifestyle, understanding what the patient's dietary history is also very, very important. And serology, IgM, IgG antibodies are key. PCR tests are not coming again, but they become positive in the acute stages where there is bacteremia. They may not come positive in the chronic stages. Blood culture is something which but it has these are the tests which are present. Now, case 2. gone through multiple times, but I just want to shed some light on this case as well. This was actually a friend of mine. I fever 103, 104, severe fatigue. He software engineer working in Mumbai again. But this symptoms were present for 4 days with chills and body aches. He had mild electrolyte pain, generalized fatigue, no rash or variant presentation, started paracetamol. Naturally, the general practitioner advised the CBC. And of course, dengue, NS1, IgG, IgM, along with NP. So, we've seen this case many times, is positive, and we know that this is a case of dengue. Now, this is a dengue, electrolyte negative, and was also negative. This patient was advised hydration and supportive care. The issue is now on day 5, this patient presents with persistent fever, again 103, 104, severe fatigue, was unable to move from the bed, he had severe body, he had gums and abdominal as well, and also had severe abdominal pain with mild resistance. Repeat CBC showed a platelet count which had drastically fallen from, in fact, previously the count was 1 lakh. It had drastically fallen from 1 lakh to 40,000. The hematocrit had gone up to 46%, and the possibility of secondary dengue infection with severe manifestations had actually come into the picture. We know that NS1 antigen is a diagnostic test. We also know that IgG and IgM are also used in dengue cases. But I want to shed some light on some other tests also which can help us to leave arrive at diagnosis of secondary dengue. Now, in this case, the serum ferritin levels were 3000. Now, we don't really look at ferritin as a marker for dengue, but we all know that ferritin is an acute phase reactant, and it will rise at any kind of acute conditions, and that's why using it to diagnose high-intensity anemia as well as fever is not a good idea. But in dengue specifically, we have found that in secondary dengue, the level of ferritin, which are normally much lower than 500, will cross 1000, 1500, 2000, and many cases we see 3000 as well. Along with that, there is mild elevation of the low function, which is ALT and AST, and the prolonged PT. So PT, APT, INR also will be prolonged in this case. So in secondary dengue, what should we do? So if we have the confirmed diagnosis of dengue, what we can at least do is we can do from the day 3 or day 4, we can do an IgG IgM, because the IgG IgM ratio, anything above 1.5 to 2, will give a higher chance of it being secondary dengue. Because in primary dengue, only IgM will be higher, but in secondary dengue, the IgG rises much faster than the IgM. So the IgG to IgM ratio will be higher in secondary dengue. Along with that, we can use LDH, which will also be elevated, PT, the liver involvement, and of course, ferritin. So these are some of the markers of severity, where the high ferritin level is one of them, a rapidly decreasing platelet count. In about 24 to 36 hours, if you are rapidly decreasing platelet count, that's one more sign, and we should keep it in mind. And of course, we know the treatment of dengue, which is now hospitalization, fluid management, is required platelet transfusion, etc. But monitoring of CBC, ferritin, liver enzyme, coagulation profile is very important, and the ferritin levels, as the treatment continues, will continue to drop as the inflammation subsides. So this is a very important surrogate marker of secondary dengue as well. So these are like I said, high IgM ratio, platelet and serum ferritin of 1000 suggests hyperinflammation. So please keep that in mind as well. Now this is a very interesting case. You know, when the marathon season starts, then we have all these patients coming with different presentations. But this person had a sensation of burning in the feet every night for 3 months. And it was progressively worsening. There was tingling in the toes, but there was no motor weakness. There was no swelling in the leg either. And more than 50 kilometers a week, non-smoker, no alcohol intake, balanced diet, if you have vegetables as well as non-vegetarian food. So initially there was no evidence for diabetes. He just had these symptoms. So the routine diet, CBC was within normal limits, liver function, fasting glucose, HbA1c, and the thyroid test all were within normal limits. So the clinician considered all these possibilities as one of the sensation in the legs. So most of these already ruled out, especially diabetic neuropathy and alcoholic neuropathy between deficiencies. But what do we do? So we test for all of these things. Between beta levels of normal, then when we tested gave up negative, autoimmune workup was within normal limits. And the only thing which came actually positive in this case was of nerve conduction studies where it showed a mild sensory change. There was no motor weakness at all. Again, this case shows us the importance of history taking, because when we actually asked him the history, then he told us that he was taking B6 tablets for a long duration of time, and also had gone to one of these wellness clinics where they gave IVs. In the kind of multivitamin sort of IV over 3 or 4 hours, and we done it 4 or 5 times in the last 2 months. So we know that for pyridoxine, we need to do the serum between B6 test, but along with that, also the homocysteine levels and the MMP levels. The homocysteine levels are normal, MMP levels are normal, but the serum between B6, which is pyridoxine level, was 90 microgram per liter, which is highly elevated. The normal is between 5 to 30 microgram per liter. Now, this case is a case of pyridoxine toxicity, and it is not something which we commonly see, but we have to keep it in mind because nowadays supplementation has become very common in clinical practice. So what basically happens is that pyridoxine will inhibit the myelination of the neurons and cause neuropathy because of that. Any dose which is above actually 500, but in this case it was more than 1000 milligram per day. Anything above 500 or in fact 250 milligram also can cause certain depending on the person. So this is again one more differential diagnosis. This was diagnosed with SAS technology, and it was found to be pyridoxine toxicity. So require a systematic diagnostic approach. It's an often overlooked cause of neuropathy, and detailed history taking is very important. If he has not been taking it for a long time, then stopping of the pyridoxine can prevent permanent nerve damage. But it takes about 6 months for the symptoms to go away after you stop pyridoxine. The fourth case is a 60-year-old male diabetic who had presented with persistent cramps and fatigue for the last 3 months. Now, this patient also had occasional palpitations. This patient was being treated on metformin, losartan, and a loop diuretic for hypertension. All the investigations were done, like sodium, all the electrolytes were normal. The renal function test showed creatinine was normal limits, glucose was normal. But whatever the other investigations were, that the HbA1c was still 8, it was still poorly controlled. So in this case, the doctor advised also to do a ECG because of the palpitations. Now the ECG and Holter monitor actually showed occasional PACs which are premature atrial contractions. So with a normal electrolyte, but with premature atrial contractions in a diabetic who's on loop diuretics and who's on metformin. First of all, metformin we all know would sustain bigger deficiency, right? But that had been ruled out for the screen because of absolutely normal and was already on bigger supplements. So then what else do we have to keep in mind when you have PACs, patient has loop diuretics? So in these cases, serum magnesium levels are very critical. Actually, serum magnesium deficiency is more common than we realize, especially on people with loop diuretics. And serum magnesium deficiency has a lot of fallout. For example, if you have hypomagnesemia, it also causes hypokalemia. And until you treat the magnesium hypomagnesemia, you cannot actually treat the hypokalemia. The same thing happens with calcium. Because magnesium reduces hypomagnesemia or hypocalcemia as well. So if you see a patient which has unexplained hypocalcemia or unexplained hypokalemia, then please look at the magnesium levels also. Because treating the magnesium levels will help you treating the calcium and the potassium levels. So this is again, in this patient, there was 2.2, which I tell you is the this is enough for us diagnosis. Also need to do a 24-hour urinary calcium, which is it tells you whether the calcium excretion in the urine is higher than normal, and if it's more than 25, it is higher, and it was found to 50 mg per day. So the cause identified was actually loop diuretics, which causes renal magnesium loss. So the magnesium deficiency is underdiagnosed. If you have diuretics, unexplained cramps or fatigue, then you can consider to do serial magnesium levels. You may have to be using the excretion of magnesium. And looking at levels, as you know, you don't include the magnesium levels. So sodium potassium and calcium may be normal, but you still have to consider this. Now, the fifth case is a female who actually had a chronic cough for 3 months. She was no case of pulmonary tuberculosis a few years ago, but it was completely treated 3 years ago. She had been taking, she had mild hemoptysis, there was fatigue and weight loss around 5 kg over 3 months. She works as a housekeeper, but she had currently not moved fever night sweats or wheezing, but she did have hemoptysis. Now, the ESR, the hemoglobin was 12, WHO 9.200, but the ESR was elevated at 75 milliliters per hour. Now, the chest X-ray findings showed a cold right upper cavity with mild opacity around it. The students, again, the students here at the gene expert testing were negative. She was started on empirical antibiotics for presumed bacterial bronchitis, but the symptoms persist. So, what should we keep in mind when we expect cold tuberculosis? So, what happened was, again, 2 weeks later, the hemoptysis increased. The fatigue percent. The ESR also rose slightly and CR. So, if you have persistent symptoms in a post-TB patient with hemoptysis, it points to a fungal etiology or it points to a malignant etiology. So, these were the various different diagnoses to consider: post-TB bronchitis, pulmonary TB reactivation, chronic pulmonary aspergillosis. Malignancy suggests that there was a history of this, but it's still something to be kept in mind. And other fungal infections like histoplasmosis, mucormycosis. Now, how do you differentiate between all of this? The first thing was carried out was CT test. It showed they got right to the upper cavity with a short central soft tissue like a fungal wall surrounding ground glass opacity. This was the yellow sign. Now, on the student culture, there was actually on the microscopy we can differentiate the hyphae of the Aspergillus species. And the growth of Aspergillus is very difficult. It takes a long time, but it can be done also. But the test I want to point out here is the galactomagnet antigen test, which actually finally confirmed the diagnosis as well. So galactomagnet is a test which is an optically density reading. Higher the value of galactomagnet, of course, it confirms the diagnosis of individual aspergillosis, but higher the value, it also tells you the severity of the case. And second is the beta glucan, which is also positive, which supports a general fungal infection. It is not specific for aspergillosis. So galactomagnet is specific for aspergillosis. So the diagnosis of chronic pulmonary aspergillosis with the organization of a cold TB cavity in Aspergillus nigra. This diagnostic criteria was met, which was symptoms for more than 3 months, imaging showed a fungal wall and a positive microbiological evidence. In this case, antigen was also positive. So CTA is treated with itraconazole 200 mg BID for 6 months, monitoring of liver function till during therapy, nutrition support, and if required in some cases, the locally may have to be done. Another use of galactomagnet when you start the patient on treatment, you can use galactomagnet to actually titrate the dose also, and you can see if the galactomagnet is dropping, then you know the itraconazole is actually working in this patient. So it's also used as a prognostic marker and to guide the treatment as well. So post-TB cavity is a high risk of aspergillosis, and early diagnosis and antifungal therapy can prevent severe complications. So this is a comparison. So we can look at not specific aspergillosis, galactomagnet antigen is the primary test. Now, this case is a case where a 61-year-old with persistent seizures by treatment. So this patient had a diagnosis of basically he was taking anti-epileptic drugs for a long duration of time and therapeutic doses, antibiotic and carbamazepine. He has been taking the medication regularly, but why are the seizures still available? So an EEG was done, which confirmed epileptiform activity. The serum blood level was therapeutic with therapeutic range. MRI rate was normal. So in a case who's taking medications whose drug levels are normal, why is the medication not working? Because the MRI ruled out any other cause of epilepsy as well. So then this I covered in the last lecture. I thought I should again speak about it. There is something called as pharmacogenomics, where it is a study of how a person's genes affect their response to drugs. There are a lot of gene basically tests, about 200 genes, I just listed some of them here. So what this basically allows you to do is you can check whether this drug is going to act on this individual, whether it's going to cause side effects, and whether you need to change the drug. Because this drug might not even act or it might cause severe side effects in certain people. So in this case, particularly, the CRP 3 4 5 gene was tested and found that there was a low metabolism. So there's a impaired metabolism of ADs like carbamazepine, so the efficacy would be reduced. And there's another UPCB1 gene which was tested. This tells you that there is reduced transport across the blood-brain barrier, and that is why again the effect of TAPI and TAPI plus will be reduced. This is how the report comes. It tells you what to avoid, what to use with caution, and routine you don't have to change it. So patient is okay to take this. This is how it looks. In this you see the red, which was carbamazepine and xelatone as well as phosphate. But in this patient also, the clopidogrel was something which you cannot give or cannot work on this patient. So you have to change clopidogrel because otherwise there is no use for the patient. So in this case, if you switch the AEDs, then you can start levetiracetam or valproate, you have to monitor the response, and then you should see the seizure frequency. So the idea we have telling about pharmacogenomics is that it can be used in multiple medications, in all the commonly used investigations or commonly used conditions like diabetes, hypertension. Most of the common medications can be tested for, like metformin is used on a regular basis, amlodipine, losartan, for infections, augmentin, azithromycin, etc. So it reduces trial and error prescribing, prevents adverse effects, enhances efficacy, and also improves the compliance. Because there are less side effects, the patient is more likely to take the medication for a longer duration of time. And the last case for today is a 38-year-old athlete. This is again somebody who came to us last July. He had a dry cough persisting for 6 months, and this started in July 2023. There was mild throat irritation and occasional fatigue, but no other symptoms, just a dry cough, and this carried on for 6 months. He was a tennis player, he had no known allergies, no history of asthma, non-smoker, no alcohol intake. Initially, his hemoglobin was 11.5, WBC platelets were normal, but the only two abnormal findings, only two abnormal findings was high blood sugar, which was 220 mg per day, and a very high total IgE count of 12 hours time per day. So these are the only two things that were positive. He was sent to the endocrinologist or the pulmonologist also. The endocrinologist put him on metformin to control the diabetes. He was diagnosed with diabetes type 2, and the pulmonologist actually did a PhD, and actually there was no evidence of allergic bronchial asthma, but the elevated IgE showed that it could be allergic asthma. So he was diagnosed with allergic asthma. Over 2 months, the cough persisted, there was minimal improvement. In September 2023, again, for persistent symptoms, a PhD was done, chest X-ray was done, it was normal. So now they were saying that the stress related cough was low pressure and lifestyle. So that is counseling. December 2023, again, no significant improvement in the cough. Now he suddenly noticed a lump on the left armpit. He had gone to a senior doctor who said that this is a fat deposit. You can ignore until you take your asthma medication should subside. In January 2024, he was traveling out of town and over there had severe reflux and vomiting. And he came back, visited a gastroenterologist because of that, endoscopy normal, chest CT scan unremarkable. So GI process ruled out. But then the hemoglobin dropped to 9.8, and he visited the GI again to do a lower GI scope. Serum presentation was again normal. So there was no evidence of bleeding from anywhere, no iron deficiency, etc. So what would be the cause of this persistent cough and progressive anemia? Because the hemoglobin further declined to 8.8, the doctor suggested to do a PET scan. In this PET scan, it was found that he had hypometabolic nodules all over. So it was axilla, the media timing, etc. Diagnosed on biopsy and lymph node biopsy, Hodgkin's lymphoma with hyper IgE syndrome. Treated on BVABD, and it was basically the point of this case was that a chronic cough with hyper IgE finally ended up with Hodgkin's lymphoma. Any persistent symptoms with high IgE, please consider other possibilities as well. Thank you.
Thank you, sir. Thank you, speaker. And also consider I request Dr. R.P. Joshi sir to remove the lecture. Thank you, and I request Dr. Avinash Bhatt sir and Dr. Mdmpa to please come on the stage. Thank you, Dr. Mohan.
Just a small compliment for Dr. Ajay sir. सर हम तो चले थे अंधेरी राह पे आपने भी उजाला कर दिया
Now I request Dr. Kailash Gaur and Dr. Sri Kamli to facilitate our chairpersons.
President, chairpersons too. Thank you, Dr. Kailash. Thank you, Dr. Sri Kamli.
Yes.
Thank you. Good start.
Thank you for this, sir. Our next speaker is Dr. Mdmpa, sir. सर ये एक गाना होता है, जिंदगी कैसी है, जिंदगी कैसी है मेरी हाय, कभी ये हंसाए, कभी ये रुलाए,
और ऐसी ही पहेली को सुलझाए, कैंसर के पेशेंट्स का दर्द को मिटाए, सुशील और शांत डॉक्टर प्रसाद. And I would like to call for the chairperson for this session, Dr. R.P. Joshi and Dr. Mdmpa Kaur. Dr. R.P. Joshi sir, अगर ध्यान से देखोगे, तो he resembles like the founder of homeopathy, Dr.
बिल्कुल बिल्कुल.
He is our senior and the most committed member. He has taken charge of all the respected posts of the committee. He has been practicing in Mahi for 34 years and is also a past president. And to accompany him, we have with us Dr. Mdmpa Kaur. He is a senior and husband in establishing Chopra Nursing Home in Mahi.
Good morning. Cancer is spreading with swings in the society like never before, affecting every age group. And a general practitioner is the first point of contact for every patient with any worrisome symptom. So it is our duty to be updated with therapies, diagnostic procedures, and all the modalities which are available. And today we have a very eminent speaker with us to enlighten on this topic, cancer in general practice. Ladies and gentlemen, please welcome Dr. Prashant Mullar, a consultant oncosurgeon affiliated with Raheja Hospital, Leelavati Hospital, Shushu Hospital and Apollo Hospital in Mumbai. He specializes in gastrointestinal, hepatobiliary, pancreatic and head neck surgeries and has been in this field for over 25 years. He is one of those rare surgeons who is skilled in both open and laparoscopic surgeries. Outstanding academic qualifications after his master's in surgery. He has had his fellowship from the esteemed Tata Memorial Hospital, from the Royal College of Surgeons in Edinburgh, advanced GI hepatobiliary cancer surgery training in Nagoya, Japan, and he's also worked with the UK NHS. He specializes in procedures like gastrectomies, colonic and rectal resections, Whipple surgery, pancreatomies, bowel resections. He has also managed oral cancers with neck dissections, mandibular resections, and glossectomies. And Dr. Mullar, we are eagerly awaiting your enlightening talk and hoping to take some very good take-home messages. Thank you.
Thank you very much, Madam, for the kind words of introduction. Good morning, everybody, and thank you very much, Mdmpa, for giving me this wonderful opportunity. So my talk basically, I'm going to focus cancer in general practice. What as general practitioners we need to observe, what we need some basics of cancer. Okay. So now what we see here is obviously a relay race. There is a baton and two hands. So one of them is your hand and one of them is my hand. The baton is the patient. So what I need to tell you is that when you hand over the responsibility of your patient to me, I assure you that I will take care of your patient and hand it back to you. Why? Because I need you to look after him after I have done my bit. Okay? Now, as Madam said, cancer is a rising problem. Now, 2008, when I was researching, you see that people dying from cancer was almost 75 lakhs. Now it has gone to 1 crore, 10 million deaths. That's a very big number. Now, this slide you see, what you need to see is the green and the other side. Green side is Asia. और उसमें से अगर आप देखेंगे तो इंडिया का जो पाया है, जो इंडिया का नंबर है कैंसर का, that is fairly high when you compare it to the other countries, यूरोप में, अमेरिका में. So India में it's a big problem. Along with diabetes, we have cancer following suit. Now India, site-wise, males may we know that these cancers are common and ये ऊपर नीचे चल रहा है, but there still remain lung cancer or oral cancers, prostate cancer in the males, and females may breast and cervix. Alternate चलते रहते हैं, but breast, cervix and ovarian cancers are very common. So cancer can affect anybody. So we need to be vigilant. Young, old, middle-aged, it just about affects everybody. Now we cannot think of cancer as one disease with one cause. So there are over 200 cancers in the body. It's a complex thing. So it's a multifactorial reason for cancer. Now these are the known etiological causative factors for cancer. उसमें से you obviously see that tobacco is a big chunk. Diet is very important, and then you have the other issues like infection, gender-related cancers. You see again tobacco. So tobacco is a very important causation for cancer. Now some infection-related cancers. Now I just wanted to see how practices human papillomavirus, hepatitis B or C virus, and liver cancer. And Helicobacter pylori for the causation of gastric cancer. Helicobacter pylori, we need to identify those patients with chronic dyspepsia, upper GI discomfort, endoscopies. If they are getting H. pylori, please let us treat them. Hepatitis B virus also, if we know patients who are carriers and are HPV positive, we need to work on these patients for liver cancer. Now, hereditary cancer is a list, but yes, for as far as I am concerned, the most important list is familial and adenomatous polyposis as a causation for colon and rectal cancer. Now, occupational carcinoma, this is a list for completion. So, cancer develop because of a complicated interaction, as we now understand, between our genes, the environment, and chance. There is a dialogue in some of the pictures of बैठक खराब है, something like that. So, अभी now normal body cells, they grow, they divide and die in an orderly fashion. So this is programmed cell death or apoptosis. Like you have your iPhone, it's a programmed death. Charge साल में iPhone डिलीवर वाला ही, it will not run. So similarly, our cells also, it is a programmed death. Now, whenever this does not happen or there is an interference with this is when you have development of cancer. So, cancer cells, you have a lot of, you see these different colored balls? Different colored balls means they are not just eight cancer cells, eight type का नहीं रहते. उसमें there is a lot of different gene structure. So, this is what we need to understand. So, because of this different hyperzygosis which is there, in अलग-अलग है, एक बॉल नहीं है. So, one treatment will not be the answer for all the cancer or a particular cancer. Now, again, this is just a little basic. I'm sorry it's a complicated slide, but maybe this will help us understand. अभी ऊपर आप देख रहे हैं जैसे normal cell. अभी normal cell में you have environmental things like chemical radiation. So there is damage to the DNA of the cells. Now, the cells, if they recover, then they become normal. But if there is a problem, there is a mutation in the gene, in what is coding the cell, or there's some software disruption in the cell, that's when you have the cancer developing. So you have genes which increase the cancer and genes which suppress cancer formation. So whenever there is a disruption in this, that is when you get cancer. So simply put, you have tumor suppressor genes there. So tumor suppressor genes means they will suppress the formation of cancer cells. If they are disrupted, or if you have activation of genes which are promoting growth, that's when you get cancer. Now the difference between benign and malignant, you see that the blue line there, that is basically membrane. So benign cells mean cancer cells will grow, but they will not invade. And malignant obviously they will invade the basement membrane, and then that predisposes them to spread. Now if you take a look at this slide, you see transformation here, angiogenesis here. So there's a lot of things that are happening during the formation of cancer cells, and that is what we are doing now as far as medical oncology is concerned, to destroy cancer cells, to destroy the angiogenesis. Means angiogenesis is formation of new cells, blood vessels. So if you have blood cells that is going to destroy the formation of new blood vessels, then the cancer cells are going to go away. So these are hormones of cancer cells. Cell-based replication, they will just replicate. They are longer survival, very strong, genetically unstable, and that's what they are looking into nowadays. And capable of producing neoangiogenesis, these naya blood vessel formation. So if they are able to attack these cancer cells at every point, that's something they are able to get a lead. So early cancer is asymptomatic. So what we need to be aware is early diagnosis, and these awareness is what we need to be aware of. Now screening is a very important aspect. Now it is preservative identification of unrecognized disease, which means you try to identify the disease before it is picked up on the symptomatology. So screening test has to be most important in our structure, not only cost effective, but it has to be sensitive, it has to be able to pick up. Now these are the common cancers which can be screened. Now in India we don't have a proper screening program, but as general practitioners we need to be aware that these are the cancers which can be screened. Cervix cancer, pap smear, breast cancer, mammography and clinical examination. Colon cancer, there is a strong history, yes. Now this slide, this again you see complicated, but if you see that arrow says limit of clinical detection and post-death. So below that limit of clinical detection on the left side, your cancer cells are not going to be detected. So any cells less than 10 raised to 9, they are not going to be detected. So relatives come and ask me, "Kitna din se hai?" We don't know, because we don't know the starting point. So these are some of the diagnostic tests for tumor markers for cancer, but I don't usually recommend that we get tumor markers done as a screening. So our goal has to be curative. That is where we should be able to operate and move the cancer in totality. Adjuvant therapy, this aims to eradicate the microscopic cancer after removal by surgery. And palliative is when cancer is so advanced that we need to just give symptomatic treatment, help the patient to tide over the crisis. So three main modalities of cancer treatment, either in surgery, radiotherapy or chemotherapy. So it is only a permutation and combination of these treatment modalities. So when we are talking of treatment for cancer, so either it is removed by surgery or we block the angiogenesis or we give chemotherapeutic drugs to reduce or halt the cell division of cancer cells. Now, the history of the surgical approach. Now, surgical approach, it was the first modality which was used successfully for the treatment of cancer. For common solid tumors, it is curative, but provided there is no distant metastasis or extensive local infiltration. And even with distant metastasis, we may be able to operate certain cancers. For example, if you have colon cancer or rectal cancer patients who have their metastasis, we don't just write them off. So we treat them first with chemotherapy, reduce the cancer load, then go we can operate in the metastatic side as well as the primary side. Frozen section is something that we use in our practice to see whether our surgery is complete. Resection of sampling of digital lymph nodes and lymphadenectomy, that is an essential part of the surgery also. Now, radiation therapy. So, radiation therapy is mainly a local modality, but the cancer tissues can be radiosensitive. So, you have two main methods, either external beam or brachytherapy, that is the very close application of radiation to the cancer cells. So, radiation therapy involves ionizing radiation which destroys the cancer, the linear with the cancer cells, and causes them to get destroyed. Or, so, once these cancer cells are destroyed by the genes are destroyed, the linear is destroyed, then they are gotten rid of by our body. Now, even this is just I'm going to take you just an overview of radiation. Now, this is the conventional radiation where you see that along with the tumor, you have organ 1 and organ 2. Now, previously what used to happen is that with the radiation, even along with the tumor tissue, the normal organ also used to be affected. But currently we have advanced radiation techniques where your side effect to the organs is limited. So this is IMRT, which is intensely modulated, and there is also image guided radiotherapy. So these are little, I'm just touching on the principles. My main point here is that all these methods, whether it is radiation, chemotherapy, unfortunately they are cost intensive. Cost hota hai. So we need to help the patient through all these crises. So radiation therapy, acute and long-term toxicity, these are known fatigue, local skin reactions. We've all seen that. Chemotherapy against the use of drugs, as I said, chemotherapy functions by killing cells which are actively dividing, and therefore because they are affecting those, you do get side effects. So you get side effects like nausea or loss of appetite and things. So this is an interesting slide. So if you see that once you have achieved a certain number of cells which is forming a tumor, you do surgery, then you see that eye going down, and then you are able to give chemotherapy, and then you get the cells come down to zero, so you achieve a cure. Or you, if you are not able to achieve, then the cancer cells just increase, and then that leads to death. Now this is another aspect of chemotherapy. My friend, I think Kunal is going to talk later on this, so he may explain. Hormonal therapy, where you are using drugs which are for hormone-sensitive tumors. So hormone therapy is predominantly used in breast cancer. You have ranitidase inhibitors, letrozole, fosfolate, tamoxifen, that has been used for a long time. These are all hormonal treatment. Now the current that we all have been hearing, immunotherapy, targeted therapy. So these are all aspects of biological therapy, targeted therapy. So where we are trying to minimize the side effects. So it is important for us to know in this maze how to go around. Because only one kind of treatment cannot, because many patients come to me for surgery, but I have to convince them that now we need to go with radiation or chemotherapy first, destroy the circulating cell, cancer cells in circulation, and then go ahead with surgery. So this slide, we should spend a little time on. This is what we need to inculcate to our patients. Lots of fruits and veggies, maintain a healthy lifestyle, exercise, and most important, awareness. So, just a brief on breast cancer. It can affect any patient, whether it is young, middle-aged, or old, just doesn't matter. Patient is presenting with a painless gum, or there is a nipple deformity. Here you see there is a deformity in the breast. Again, here there is nipple retraction. Even males can get breast cancer, so we need to be aware of male breast cancer also. It's about 1%, but it is there. Now, for diagnosis, what I would suggest now is please send your patients for true cut biopsies and not FNACs, because we are doing our FNACs for breast. For thyroid, FNAC is acceptable, but please not for breast, because that core biopsy or the true cut biopsy gives a actual tissue, and we can do the hormonal studies, the markers also from the biopsy, and that is important for us for breast in planning treatment. Because if you send them for FNAC and then they come to me, it is just a repetition of me asking them to get the biopsy done again. So this is how a mammogram looks for breast cancer. So for any breast cancer, a sonography, mammography, good clinical examination, and true cut biopsy. Now, whether it is this, I'm sure all of us know. Now, whether it is mastectomy or breast conservation, the results are equal. But yes, there are certain issues. As I said, one shoe size does not fit everybody. So we need to tailor the treatment depending on the patient, the breast size and everything. So this is just a picture of a mastectomy, how it looks. This is I've completed the axillary dissection and saved the nerves and the vessels. This is a photograph you can see of a LD flap. So we can, along with the mastectomy, we can combine it with reconstructive measures. So you see that on the right hand side there's a breast implant, and there's a good cosmetic result that we have achieved. Now, these are the American Society guidelines. Annual mammograms at 40, or at least they start at 50. Once in 2 or 3 years is what is recommended for breast cancer screening. Now, cervix cancer again, because of the common cancers, post-menopausal bleeding, post-coital bleeding, intermenstrual bleeding, foul smelling discharge, we need to be treated for cervix cancers. So this is how it looks on a spectral examination. We have growth in the cervix, so we can do either a pap smear or a biopsy. For cervix cancer screening, these are NHS guidelines at age 25 and thereafter with pap smear. Now, this is what we need to remember as general practitioners, that 70% are caused by HPV, 16-18 states. So you have vaccines which are available, but we need to make sure that the vaccination happens in the girls, in the young girls between 12 and 13, before they start their sexual life. So, management again, whether it is Volines or a combination of radiation and chemotherapy. Oral cancer, again, very common cancer. Tobacco is most important. But let me get to a stage before oral cancer. So you see these white patches, these are leukoplakia. This is the invasive cancer. There is a clear-cut ulcerative lesion. Like floor mouth, they happen anywhere in the oral cavity. You see this ulcer on the floor mouth, they are typically painless. And they will be there for 1 or 2 months. So this is a surgery that we done the neck dissection, we remove the primary, and reconstruction either by flap or by pedicle grafts. Now I'm not going to go too much in detail because I think Sanjay is going to talk about this. Sanjay Joshi is going to talk. So this is large complex tumors in the neck. You see this largely eye adenomas. Now this lady came with a parallel sinus tumor. Ethmoidal sinus tumor, which I have excised. So this is again another picture of parapharyngeal tumor. We have safeguarded the nerves. Gastrointestinal cancer, all scale cancers will present with dyspepsia, weight loss, loss of appetite, low hemoglobin, change in bowel habits, most common, and jaundice also. So this is esophageal cancer. You see the endoscopy, there is a tumor there. Dental cancer, as I said, bleeding here, and we've done an angle resection here. It's a stapled angle resection that is done. GI sarcomas, they present with abdominal pain and discomfort. Liver cancers. Now, this is, I was talking for a while, the very interesting case area. So, this lady, she presented with bleeding here. The endoscopist did the colonoscopy and he was confused because he said, I will be a fistulous tract. So, what happened was that if you see that there is it's a large ovarian cancer, okay, and you see that there is a uterus there. If If you see the marker, there is a uterus and there is a fistulous communication between the uterus and large bowel, sigmoid bowel, and also the uterus and the ilium. And there's a large, and the greyish thing which you see behind is a large cystic lesion. So it's a solid and cystic lesion of the ovary. So that's what I did. I did hysterectomy along with sigmoid colectomy and ideal resection anastomosis. You see that scissor now going in. So that is the scissor has gone through the uterine cavity and the sigmoid and the small bowel. Patient did very well. She went home and ileostomy. She's recuperating now. Start chemotherapy very soon. So these are again cystic ovarian masses. Now, this is another interesting tumor that we get as tumors in the tail of the pancreas. You see this the tumor attached to the tail of the pancreas. Now, we put a tape around the body of the pancreas. So we dissect all around the pancreas and then we apply a stapler and take the tumor out. So this is a mucin cystic tumor of the pancreas. Gallbladder cancer, yes, I need to talk about this. Gallbladder cancers are very commonly seen in people, especially coming from North India, from UP. Now, this you see is on the right hand side, you see the photograph. It's a small localized tumor. But gallbladder cancers are aggressive tumors. Sometimes the patients come with metastatic disease or motor disease, and we need to treat them with upfront chemotherapy first and then go in and operate. So this is the hepatectomy for cholangiocarcinoma, this carcinoma of the bile. So basically, in conclusion, we need to be vigilant so that we can detect most of the cancer, if not all. Screening is important, especially for breast cervix. And we need to be vigilant for warning signs like leukoplakia, that is white patches. So let us fight cancer, which is a global problem.
Thank you, sir. Thank you, sir. I'm happy to take any questions. No, sir. No questions. No questions about, sir. Thanks. No question and answer sessions. But thank you for sitting on to this. And we already done it.
That was, I'm sorry, that's why I must have seen a little rush. Thank you so much.
And I request the chairpersons to please consider the speaker.
Now I request Dr. Satya Devekar and Dr. Ramji Singh to come on the dais to felicitate our chairpersons.
सर आप भी आ जाइए.
Lucky player Kaushik Desai and Dr. Kiran Awali. Dr. Kaushik Desai and Dr. Kiran Awali.
Nice, please. Thank you.
Request the audience not to leave. Please get seated.
Please be seated.
Please be seated. Shrikant, please be seated. There is a crowd near the door. I request them all to please be seated. Don't go out, please be seated in the auditorium only. Please. And now we start the next lecture. Patient को हो appendicitis, endometriosis, cholangitis, then go beyond diagnosis. चाहिए अगर आपको minimum invasive surgery in a single incision without pain, think of a human chain. Sir, जल्दी का इलाज बेदर्दी से नहीं करते हैं। And I request the chairperson.
Now I would like to call upon our chairpersons for this session, Dr. Satish Parikar and Dr. Mdmpa. Dr. Satish Parikar, our past president and now our vice president culture, Govinda Mdmpa, practicing since last 29 years in Dhari, and to accompany Dr. Mdmpa, practicing as Ayurvedic consultant since last 26 years in Dhari, our registration champion.
डॉक्टर दीपा खान आपको बता दूं कि डॉक्टर नसीम खान की बेटा और बेटा था।
Thank you, sir. Such a sweet introduction. Good morning, everyone. Dr. Mdmpa, sir, laparoscopic and GI oncosurgeon. He has done his graduation from PG Medical College, Pune, MS General Surgery from Lokmanya Municipal Medical College, Mumbai, ACH GI Surgery from All India Institute of Medical Sciences, New Delhi. He has been practicing in Mumbai since 2017. He is a consultant at Leelavati and Siddhanchal Hospital. His today's topic is single incision laparoscopic cholecystectomy. Just a small here belly button scar. Sir, dice is yours.
Thank you so much. Very much good morning to everyone in the hall. Thank you so much for a very pleasant and poetic introduction. Never had such a beautiful introduction before. Good morning everyone. We will start the topic without much ado. Voltaire appendix inguinal hernia. ये आपने लाइफ में 19 cases सबके पास आते हैं. Most of the surgeons will make 3-4 small incisions and operate. We have gone a step further in that. So there is a slight question that we operate by a single incision. How it happens, why we should promote this, why it is nice and good. We'll just have a look at it. So we'll start with a small case. It's a 62 years old female in pancreatitis, already a very good stage of cancer. The study began with therapy, and she underwent ERCP stenting for the stones in the binder, CT, and then was subsequently planned for further surgical management. We had posted her for surgery. Now, when patients come to us, what do they want? What do they want from you as a general practitioner, from me as a consultant? They want treatment, they want relief, they want treatment which is long lasting, they want things so that the problem will not recur to them. And if they are able to do all these things and in a cost effective way, in a way to give good cosmesis to the patients, that's a bad advantage that we can see. So gallbladder is a very common problem that many of us face. What are gallstones? What are the problems with the gallbladder? Gallbladder is small pear-shaped organ located on the undersurface of the liver. It is a cause of many maladies. The dysfunction of the gallbladder organ per se leads to formation of stones, and which can cause problems like pain, jaundice, pancreatitis, many other things. Do all patients with gallbladder stones require surgery? Absolutely no. All patients don't need surgery. If you do ultrasound of people walking on the road, out of 100 people, 15 to 20 of them will have stones. Do we operate all of them? We operate until gallstones are causing trouble. If they are causing symptoms, if they are causing pain, if they are gone into the bile duct, they require ERCP, if they are pancreatic in the past, those are the patients who require surgery. Amongst the category of patients who are asymptomatic, who never had pain in their life, we have to select out some patients which will benefit from surgery, so that the risk-benefit analysis favors surgery. So we tend to operate patients where the stone is large, because a large stone indicates it's been there for years together. So we don't want that stone to cause cancer in future. We will operate patients who are from UPB or Northeast because the incidence of malignancy in those areas are very high and almost 90 to 95% of the cancers are associated with stone formation. Any patient with a history of cancer in the family, we will offer surgery. We won't offer surgery to all the patients. So when you talk of surgery, how is it done? 20 years before it was open surgery. We used to take a small cut on the right upper quadrant and we used to operate it with the traditional way of operating a gallbladder. Then came the era of laparoscopy. We used to make a small incision at the navel and 3-4 small incisions outside and we used to operate and remove the gallbladder. Now we are going to step further into this. We take a small incision at the navel. All the 3 instruments go into the same incision and we are able to remove the gallbladder in 99% of cases through that single small incision. The image on the right, that's the at the end of the surgery. That's what we give to our patients nowadays. So this lady had a surgery in June 23. She underwent a single incision laparoscopic cholecystectomy. It was an uneventful surgery. Cholecyst was started as usual after 6 hours and she went home after 24 hours. She's been doing fine with about a year's follow-up. So these are the images of the surgery that we do, the single incision laparoscopic cholecystectomy. The initial panel is the incision, instruments going in. The second panel you see the gallbladder being dissected and being put into the bag, and then there are 2 images of the post-op scar. These are the scars after surgery, they are not before surgery. So you see there is almost negligible scarring that happens. So by offering this treatment, if we do justice to our patient, was she able to get a treatment which is long-lasting, cosmetic, cost-effective? I think the answer is yes to all these questions. That's why I put the slide earlier. This is that same patient whom we discussed. We have audio. Can we have audio? The audio is not very clear actually. So instead of praising yourself, it's nice if someone else praises you. That's why this special testimonial is nothing more than that. So what is single incision laparoscopic surgery? It's basically a modification of your traditional multi-port surgery. Instead of putting multiple rollers and multiple instruments, we are using a single incision. There are 2 ways in which you can do a single incision surgery. We can either use a commercial Swiss port, which is about 3.5 cm in diameter, will cost you 25,000 rupees, or we can do it by the technique that we do, by multiple puncture technique. So in our technique, the maximum incision on the sheet is just 10 mm, just like your routine normal 4-port laparoscopic surgery. This has its own advantages, which we will touch upon later. So what are the advantages and disadvantages? Every procedure has its own advantages. Advantages are excellent cosmesis, less pain, quick recovery, but it does have its own problems also because this is a modification of the traditional surgery. It needs tons and tons of patients, needs technical expertise, and takes a bit longer to operate. When we operate this, we use the standard laparoscopic instruments. I don't have any fancy instruments, and we use this 3 suture materials. We don't even use clips. So the costing of the surgery is very comfortable. We don't have to increase the expenses much. So I just showed you the images of the single incision surgery. The length of the incision is actually detected by the anatomy of the umbilicus. We will mark the 12 o'clock and 6 o'clock position as you see in the picture. The marks have been done on the umbilicus. This is just before we take the incision. And then the incision is made and the umbilicus is opened up. And to this space, we will have 3 instruments inserted like this. The middle 10 mm instrument is for Canada, and we have lateral 2 5 mm instruments, which will be the working instruments to which we will operate. This with the left hand instrument, we put the gallbladder, and with the right hand instrument, we will dissect out the carrots, we will coagulate the cystic artery, and we will tie the cystic artery and then cut it. Subsequently, the gallbladder is removed and it is put into a bag, and then the bag is removed from the same incision to which the instruments are gone in. I am very paranoid about closure after this surgery because what gave single incision surgery a bad name initially was hernia formation at this site. So I tend to put not 1 but 3 sutures to close the sheath incision so that the hernia nets are acceptable and they are not overbound. And then the skin is closed with subacute sutures so that there is no suture removal at the end. We start the patient on liquids at 6 hours. Within 24-48 hours, the patient that advocated I had to be there for 6 weeks, and these are the images of subsequent dressings. So is it safe? Any surgery will be done by a surgeon only if he is totally convinced that the surgical procedure is safe. There is no point tinkering with safety of the patient because safety is of paramount importance. So this surgery is as safe as a normal lap cholecystectomy. Every surgery has a risk associated with it. Every surgery has a risk of bleeding, infection, risk to life. The same applies to this surgery also. Any catheter surgery, whether it is a open, four-port or a single incision laparoscopic surgery, has a risk of hernia formation. The incision side has a risk of bilateral injury, which is applicable to this procedure also. Okay. Coming to umbilical hernia formation, when I said it can be done by a commercial Silks port, which is 3 cm diameter, we have to make a hole of 3 cm on the sheet. When you compare a 1 cm hole with a 3 cm hole, obviously the hernia depth will be higher with a 3 cm hole. That is the reason we do not use a commercial Silks port. And because we are having just a 10 mm incision on the sheet, our hernia depths are acceptable as any laparoscopic surgery. Obviously, all laparoscopic surgeries do have a risk of hernia formation, but we have taken steps so that it is acceptable. It is not overloaded. It is not more than a normal laparoscopic surgery. Because if you are operating by a single incision, the risk should not be more than a 4-port. Cosmesis is not so important that would give more trouble to the patient. Does it cost more? The costing is that of a normal lap coding. Just because it is a single incision, it will not be charged extra. In this patient, in this surgery, actually, if we look to see, we are saving on cost. Why? I am not using a clip. One clip is 800 rupees. I am not using 2 assistants. It is just a surgeon and 1 assistant. So we are saving on the manpower. So frankly speaking, if you are looking at a Western setup, then you are saving on cost. But in India, manpower is very cheap. So that saving doesn't translate to financial fees. But yes, this surgery doesn't cost more than a normal lap cholecystectomy. There are no additional expenses, there are no additional discounts. The setting is that of a normal surgery. The arrangements are the same. This is data of the initial 50 cases that I had done. Initially, I was tabulating data, then I gave up. I became lazy, actually shouldn't have done. But I started this journey of single incision in March 2021, about 3 years back. Subsequently, I had done about 500 cases. This is the data of the initial 30 cases. So we've been able to operate even patients with BMI as high as 45, which is really obese patients. We've been able to operate patients who are very old, about 87 years also. Operating clinics were comfortable, blood loss was comfortable, complication rates were not high. But complications do catch up with surgeons as you operate more and more. Because people say the only way not to have complications is not to operate, which is not feasible. You have to operate. So you will have complications. We had patients whom we had open surgery, we have had bilateral formation. But as you see, the rates are very much acceptable. 0.8% rate of bilateral injury, 0.8% rate of umbilical hernia, which is as any normal lap. Even a lap TL will have this much rate of hernia formation. Coming to what all things we do with single incision. We started off with gallbladder, but now as numbers have increased, as the expertise has increased, as the experience has come up, we have expanded this to multiple indications. We have done cancer surgeries, we have done gallbladder cancer, we have done stomach cancer, we have done rectal cancer, we have done right anticoagulants. In some patients, we required a gallbladder plus appendix removal or gallbladder plus ovarian cyst removal. We were able to do both the surgeries by the same single instrument. Initially, the instruments were facing towards the liver. We removed the gallbladder, then the same instruments were rotated and they were facing towards the pelvis to remove either the appendix or the ovary. We have done internal hernia surgeries also. We routinely do them with a single incision. So as it's a technique, as you become good at it, your indications expand. This is a patient with a neuroendocrine tumor in duodenum, which is a very difficult location to manage laparoscopically. We were able to do it with Silks+1 approach. We inserted 3 instruments for the umbilicus and an animal port on the one side of the patient because we were planning a vein replacement subsequently. We removed that incision and we sutured closer to the primary. This was in a Nanavati and the patient was very comfortable. He went on well. On the left hand side, what you see is a choledochal cyst. Choledochal cyst is abnormal dilatation of the bile duct, in which you have to remove the complete bile duct and then take the jejunum up and anastomose into the upper end of the bile duct. You will do it by pedicojejunostomos. This surgery you were able to do with a single incision, which is actually a very advanced laparoscopic surgery. You have to remove the duct, you have to take the jejunum out, you have to do the anastomosis, the hand-shin anastomosis. replace multiple sutures in the bile duct and the jejunum. All this we were able to perform via single incision, and the patient is comfortable, went off well, is very happy. It was a young female patient. On the right hand side, what you see, I don't have a pointer, unfortunately, here on the right. On the right hand side, what you see, this is the tumor. It's about 6 centimeter tumor in the stomach on the greater curvature. So this is the only scar the patient had. It was an elderly female patient. We operated nanopathy. We did a wide open excision on the stomach just, and we sutured towards the defect in the stomach handstone with the normal sutures. And the specimen was removed via the umbilicus. When the patient came for follow-up at 1.5 weeks, he said, "Sir, मेरे को लगता ही नहीं मेरा operation होगा." This is what pushes me further to operate into more and more such cases. Thank you so much. On the right side, what we see is the laparoscopic right hemicolectomy done via single incision. This is the patient of Achilles cardia. We did a cardiomyotomy from the patient via single incision approach. This is a sigmoid colectomy for sigmoid volvulus, again done via single incision approach. When we talk of cancers, we have also done gallbladder cancer surgeries. Whenever you have gallbladder cancer, you need a lot more than just a normal cholecystectomy. You have to remove the gallbladder, you have to remove a patch of the liver, and you have to remove all the lymph nodes around the hepatoduodenal ligament, which is around the portal vein, hepatic artery, and the bile duct. Traditionally, 99% of the surgeons in the world, they will do this surgery by open up, forget laparoscopy. A big incision will be taken, the wedge of the liver will be removed, and all these lymph nodes will be taken. These are the images of single incision laparoscopic extended cholecystectomy. I show you. This is the gallbladder you see. The canal being dissected. The cystic artery is being tied. We use a single-handed knotting technique. Then the cystic duct is being cut. I'm sorry, the cystic duct was being tied, not artery. We are marking the wedge dissection of the liver laparoscopically. This is the amount of the liver which will be removed with the gallbladder. We are starting the hepatectomy, liver dissection part. It has to be done slowly and meticulously because the risk of bleeding is very high whenever you cut the liver. This is the hepatectomy being progressed. We are now starting on the left side. Slowly, steadily, at times on the upper side, at times on the lower side, we circumferentially keep on dissecting the liver, keep on doing the hemostasis simultaneously. This is the final result after removing the liver. Now we are starting the lymph node dissection because for cancer lymph node dissection is equally important, and this is the final lymph node dissection completed. What we saw was the bile duct, artery, and the portal vein, and this is the final specimen. All the margins were there. This is the operating room at Nanchal, and this is the final scar the patient got. This is the specimen. This is the final dissected area. A wedge of liver was removed, and this is the single incision. Just one vein side here. That's it. Patient had an uneventful recovery, went home, no complications. So, what is the future of single incision surgery? A lot of people have now ventured into robotic surgery. There is a separate downstream robotic platform for single incision. But I don't see that as a reality because the camera itself is a disposable camera which is costing 1 lakh rupees. So, and it's a separate robotic system which the hospital will have to buy, not the routine laparoscopic robotic system. So, I don't see that happening in India at least. This is my dream. I don't know when it will be realized. Right now, I'm putting 3 holes, 3 instruments inside. One day, hopefully, I'll be able to do it with just a single hole, even on the sheet. And we will have some mechanism wherein we can have 3 instruments going in via single hole. We don't do just laparoscopic surgeries. We have done multiple complicated open surgeries also at Siddhanchal. This is the story of a Whipple surgery we did. Whipple single surgery we need to do for CA pancreas. It's quite a complicated one. It takes about 10 to 12 hours to complete. Can we play the video from your end? I'm not able to. In open surgery, ripples and appendectomy, these are the most complicated surgeries we can think of. This patient had a ripples. The video that we are taking is at the post-op day 10 and 11 when the patient is about to be discharged. He is eating well right now, all the veins are out and he is comfortable. The patient came from actually a rural background in West Bengal and they were quite happy with the treatment. This is our ICU, the nurses in action. This is the team. A surgeon cannot operate in isolation. He has to work with a team of intensivists in the ICU rooms. Multiple setups, multiple places. You all know about the hospital. I am not allowed to take any questions, but I am available outside if you have any. I can't say if you can ask me questions out here.
Thank you, sir. Thank you for saying. So, first says, minimum invasive surgery, single incision, then Turan. I request the chairperson to participate the speaker.
I request Dr. Kaushik Desai and Dr. Deepak Dalvi to come on the dais to participate our chairperson.
Yes, sir. Sir, yeah.
Lucky Deepak, Akhilesh Pal, Dr. Akhilesh Pal and Dr. Maslan Pathan.
Hi, please. Sir.
Take a quick picture. You want to say that? Thank you. And now we are ready for the next session.
It is said that a rise of orthopedic surgeon depends on the fall of the patient. Isn't it, sir?
Yes. पेशेंट गिरेगा नहीं तो सर का काम कहाँ से निकलेगा? अनूप सर,
But we have one. जो पेशेंट को अपने पैरों पे, घुटनों पे खड़ा देते हैं.
और फिर पेशेंट कहता है, लो भैया, हम अपने घुटनों पे खड़े हो गए और मेरी सुधर गई है चाल और फिर उस पेशेंट को लड़की देखती है जिससे लड़के होगा. ये रिप्लेसमेंट में धुरंधर डॉक्टर अनूप दमन. And I would like to call upon the dais our chairpersons for the session, Dr. Avli Walke and Dr. Madhukar Kota. Dr. Avli Walke is our past president, leading practitioner from Dharavi for the last 20 years, dashing, enthusiastic, ever smiling and ever ready to help. And the co-chairperson, Dr.
Madhukar Kota, sir, is general practitioner practicing at Mashika Level Camp since last 25 years. Actively participate in each endeavor of Mdmpa. Thank you, sir.
Okay. So thank you, Mdmpa, for the kind invitation.
Can I introduce you?
Oh, yeah, sure.
I welcome Dr. Mdmpa, sir. He has done his MBBS, MS, DNB, D Ortho, FCPS and MLAMS Fellowship in Advanced Joint Replacement from Liverpool, UK. He has been assistant professor in the Department of Orthopedics at Sion Hospital. Also, sir is MUHS, recognized postgraduate and undergraduate degree. He has done his fellowship in arthroscopy from South Korea. Also, he has done his arthroplasty fellowship from Germany. He is attached to Raheja Hospital, Global, Wokhart, Apollo, Sushrusha Hospital and Dhanvantari Hospital from Dhamra. So today sir is going to talk on robotic joint replacement. So, mic is all yours.
Thank you, ma'am, for the kind introduction. So before we start off with the most contentious issue, let me have a show of hands. If we are to do a DPR, how many of us will be vying for robotic DPR? Can we just have a show of hands for robotic DPR? Okay, so we have a dispel choice for robotic. Let me see whether I can change that. So when we talk of robotics, this is not a new term. This term has been devised from the word robota, which means labor and activity. The origin starts from 1921, in which there was a play and they used robots as slaves of humans. Unfortunately, it ended up as the robots are fighting in rebellion against humans and fighting for their extinction. Are we heading towards the same? Let's see. So robotics for surgery have not been a new concept. It has been 1985 that the first robotic procedure has been performed. It was used for neurosurgical biopsies. The same platform has been used in 1991 for transurethral dissections of prostate. Over 2 decades, that gave birth to ZS and Darwin, the systems that have evolved over a period of time now. What about robotics in arthroplasty? Is it a new concept? Well, that concept has started in 1980s. The first RoboDoc or Curexo company started off the system in 1986. And this was the concept of a robot then, which is a fully autonomous system, and it has evolved over the period of time of 3 decades. So what is the workflow of a robot? What do we think of when a robot comes to our mind? We think of a robot bringing a tray to serve people. In our surgical system, there's a big difference. So the workflow of robotic platforms is registration. Registration is what data we feed to the computer or the robot is what is important. So that is image-based, so the CT scan is done before the surgery and that data is fed to the computer, or else it is an image system wherein we paint the femur and the tibia while we open the patient up and that data is recorded on the robot. Once that is fed, the computer models the anatomy of the patient three-dimensionally and then that data is now displayed on the screen. I virtually perform the surgery even before touching the saw or the blade on the computer. So I know what is the balance, what will be the position of the implant, what will be the size of the implant even before I enter the OR. Once I lock my plan, I execute the plan with very, very high accuracy. Therefore, my implant positioning is quite accurate. My soft tissue balancing is very, very important. And in a knee surgery, it's carpentry just putting in an implant. What leads to result is a soft tissue balance. How will I balance the soft tissues? What robotics has done is, I can get the same kind of balance in my knee without stripping off my soft tissues around the knee. Now, as in any joint, what moves the joint, knee joint, elbow joint, shoulder joint, are the muscles around it. The lesser we violate this muscle, more will be the rehab, the better will be the rehab, better will be the balance. I think that is where conceptually we have changed in robotics. And that leads to a better outcome. So what are the types of robots? We'll touch on it just as a concept. We have got imageless and image-based as we discussed. We need to do a CT scan in image-based. Whereas we have got passive, semi-active and active robotic systems. Then there is an open or a closed system. What is an open system? The same robot can be used for multiple companies of joints. Whereas a closed system, you have one company which is married to a particular robot. So what is a passive system? Passive system, the robot just holds your jig in place and everything is done by the surgeon. So then the saw cutting is done by the surgeon, there is no haptic boundary. What do I mean by haptic boundary? The robot builds a wall around the anatomy of the patient. So even if I want to violate that haptic boundary, I have to injure soft tissue, I cannot. And that's the advantage of a haptic feedback that comes to me by a robot. So this is a passive system which just holds the saw, and I do the cuts myself. Then the active system is when the robot actually drives the entire procedure through, maybe burring. So the surgeon just sits hands folded by the side of the patient, and the entire job, once the plan is done, is done by the computer. Then there's an interactive system where I am going to control what my saw blade is doing. So I have control over what my saw is going to cut, and the robot assists me into doing that. Okay, so there are semi-active systems without any haptic boundary. So I can still violate my normal structures. That's what is called ROSA and Bellis, which are the robotic systems. And then are synergistic systems which give me a feedback, so tactile boundary. So if I'm violating the boundary, the robot stops. It does not let me enjoy any soft tissues. And that is called a haptic boundary by Navio or Cori. So robotic platforms available at this point of time, we have the Mako by the Striker, Navio Cori by Smith & Nephew, ROSA by Zimmer, QS by Max, Bellis by the J&J. So Mako in 2016, it's a closed platform of Striker. It uses a robotic interactive system with a strict haptic boundary. We need to do a CT scan which is foolproof for the patient's anatomy to be recorded on the monitor. Navio Cori is the Smith & Nephew platform, launched in 2012. It's an imageless system. So my data is what I feed to the computer. So I paint the femur, the tibia, and we follow the same policy of garbage in, garbage out. So whatever data I feed the computer, that is processed and therefore the outcome. So then ROSA in 2019, this is by Zimmer. This is again a kind of a passive robot which holds a chip and everything is done like a conventional surgery by the surgeon himself. QS automated system by Merrill. This was the birth child of QX, or the original company that had started these robots in 2020. It uses a burring system, not a sawing system. Therefore, it does take some time. We need to do a CT scan before undergoing the surgery. Wellies in 2021 by the Johnson & Johnson group. This is a saw-based system, and therefore we need to not do a CT scan, but also have a quicker procedure because of a sawing system. So this is a comparison. We'll go ahead as the time goes by. So once we know whether robotics are actually required or not, then we'll be convinced whether we want to do it or not. So why use robots? PKR is an effective procedure with a 90% survival at 10-year follow-up. But the problem is, even if you ask your patients, there is a subset of 20% patients which say they're not painful, but they're not very happy. The knee does not feel natural as it did before the procedure. And therefore, the world is evolving. What looks good on the X-ray does not feel good to the patient. And that's where the research in TKR started heading towards. That gave birth to the CPAC classification. What do I mean? And therefore, I'm standing up before you. If you see the colleague next to you, he may have straight knees, bow legs, or a valgus knee. And that's the natural knee that the patient has pre-arthritic situation. So he's been walking for donkeys of years with that kind of a scenario, and suddenly we put in the implant straight, 90-90, and the patient is made to walk. Will that patient have a natural knee feeling? And that is the question that we want to ask. Whether we can replicate this kind of a CPAC or coronal plane alignment of the knee, where you have the varus, the joint line orientation, which is mated to the patient's native knee. And that will give a natural knee feeling without stripping off a lot of soft tissues. And how can I do it? It would be by robots. In the conventional system, we plan to put the implant straight in 90-90, and suddenly with a bow leg, the patient has been walking for so long, and suddenly he's got a straight knee, and we need to strip a lot of soft tissues to balance that knee. That leads to an unhappy feeling. So what we're trying to do is, this is conventionally put in 90-90. You can see that we have stripped a lot of soft tissue. So a bow leg, we will release a soft tissue sleeve on the medial side. What we want to do right now is have the same alignment, but we just tweak the implant in such a way by some degrees so that we don't need to strip these soft tissues and have the same kind of well-balanced alignment. Well, can I ever do this by a conventional system? Never. So what is conventional TKR? What do we do in the procedure is that we don't have a tension data. We have to sublux the entire tibia, strip a lot of soft tissues, cut the bone. If we find that one side of the knee is tight, we release it. By releasing, we are destabilizing the knee. We may get a natural knee, but still we may have a rehab protocol which is delayed. We use some common points, that is, we use a tibial slope of 5 degrees for every patient, external rotation of 3 degrees for every patient. Okay, but can you imagine that all of our knees are the same? It is just impossible. It's wishful thinking. So, and once we do this common plan for all patients, and we put in the implant, release the soft tissue, and we are expecting that the patient will have a natural forgotten knee, we are wishful about the outcome. So this is a jig-based system. We put in the jigs, we put in the implant based on this jig. We want to cut 9 mm, it may not be 9 mm. What we look at the long knee alignment, it may not be that alignment, and therefore we need to have a good plan beforehand. So conventional issues we have discussed that it's a non-calibrated cut. We don't know how much, if we release, how much that gap will open. That's a non-quantified release, and therefore we rely on the experience of the surgeon. Now, from the patient's point of view, I don't want to leave anything to the experience of the surgeon. We want to have the same outcome for each of my patients, and that is why I need that kind of accuracy. So we can't have the same kind of plan designed for all patients. It's like distributing the same shoe size to all athletes. You have the same distribution of 42 size shirts to all of the delegates. With a slim fit, regular fit, or large size, they would not be happy. And that is why we need to curate our plan to each and every patient. We have realized that early post-operative pain is a significant deterrent for patients' acceptance towards the procedure. And the more we release the soft tissues, worse is the pain post-operative. So the outcome at 6 months may be the same after the patient recovers. But what about the experience of the memory of experience of the pain? So both the students will get the same amount of marks, but who will remember that study time? Less. And that is why we would want to prefer a robotic platform. So the conflict is, the doctor says everything is fine on the X-ray, but the patient says my knee is still painful, I'm not very happy. And that is what we are trying to get through. So this is the world of robotics. You can see the camera, the planning screen. These are the arrays that reflect the infrared rays. This is the array on the robotic arm. And what am I doing? I'm registering the hip now. I'm registering the ankle. This is the CT scan that is already loaded on the computer. I validate that plan. So I'm telling the robot that, look, you have the CT scan. I'm validating this on my table. So the robot says, yes, this is the plan that I have. This is the registration that you are doing on table. The plan is matched, and therefore we go ahead. So after we log the plan, we have not registered the data, we get this kind of a planning screen. Now the advantage and the beauty of this is that this is the magenta line, that's the anatomy of the patient, and the blue is the implant. I know before opening the implant, what is the size of the implant, what is the coverage, what should be the native tibial slope. I can change it by 1 degree each. I know how much tibial size to use. I know how much implant to be rotated or not. And I can move every implant by 1 mm or 1 degree in 6 degrees of rotation, which is practically impossible to do it freely. Okay? So this is the planning screen. I'm sorry, it's a little blurred. You see these gaps? This is the laxity. This is the native planning screen. The computer gives me this data. And after implanting this position of the planning screen, the implant will be loose by 4 mm and 2.5 in extension, and 2 mm lax laterally and tight 0.5 mm medially in flexion. Now I therefore can tweak the implant positioning such that I get a 0-0 balance knee. That means my knee is perfectly balanced in extension and knee flexion just by tweaking the implant positioning by 1 degree, 2 degree, 3 degree, by 1 mm, 2 mm, 3 mm, which is practically impossible to do it with a blind eye without releasing soft tissues. So I don't touch any soft tissues. This is the beauty of the haptic system. So I'm sewing in. These are the arrays plugged in. This is the robotic arm coming in. It is holding and guiding my part. I'm not even looking at the field. I'm looking at the monitor. This is the haptic boundary that does not allow the saw to go off the bone. So I'm not going to injure anything, any soft tissues around it. I'm not even looking at the patient. So this is so foolproof that you can see that now I'm going in. The plan green is locked and you go ahead and saw. So the beauty of the system is that I'm not even worried of injuring any soft tissues. My plan is locked. The whole surgery, the skill, the knowledge is all dependent on the planning screen, and rest is execution of a locked plan. Then we implant the positioning, and this is the feeling of Zen. 0-0 degrees, 0-0 mm. That's the perfect balance that you would want for every patient without releasing any soft tissues. What is the outcome? We have operated enough number of patients, relatives of physiotherapists, doctors. This is the patient walking the next day after surgery without any brace. The second day, they stair climb. And this is all because of lack of no need to release any soft tissues with a good balance sheet. I think that is why we need to go towards technology. So, dear friends, what is success? Success is not only knowledge, it is also execution of knowledge. And it's also validation of how well you're executing. So robotics helps us to have a validated execution of whatever plan we have in mind. And I think that is what is actually the objective. Every technology goes through this particular cycle. So the first stage is denial. No. I mean, you don't need to use any technology. Convention is the best. Then comes the stage of competitive need. I want to use this technology because my peers are using it. And that's the competitive need. We are still somewhere in this stage. And then a stage will come of irreplaceable acceptance. And you use the technology because that is much better than what the conventional technology was. So be it computers, internet, cars, mobile bankings, all of these technologies have gone through this technology cycle. When we talk of costs being too high for any robotic surgery, we are looking at the situation right now. We have thought the same when we are using pagers, mobiles, and look at the situation now. So as we go on with time, it's going to be cost discounted, and therefore costs will come down. Why will robotics stay? Anything that benefits stays. And why do I say robotics will benefit? Is because even if it helps in early post-operative pain, it is still worth it. If it can reproduce the same balance in each of my knee without having the stress to the patient or the surgeon, it is still worth it. If we are ready for an augmented reality, so using Google glasses to operate remotely, it is still getting us future ready and it is still worth it. So therefore, I have transitioned smoothly from conventional to robotic. I still do conventional surgeries, but given choice, robotic gives that zen feeling of complete balance without liberating any soft tissues. In conclusion, robotics have improved the accuracy of implant placements. Early post-operative pain is definitely something that we need to look for. Long-term outcomes are still not out. 6 months later, both have a similar functional outcome. But robotics now is just the beginning of technological advancement that we are seeing from our day-to-day life. So I thank you for your patient hearing.
I am so happy, sir. Thank you. And after this Dhamakata lecture from Dr. Raman Gaonkar, I request the chairperson to please felicitate and thank him. And now his slide change. And Dr. Harish Kata will take the report of the yes,
Now I request Dr. S.P. Athani and Dr. Mdmpa to come on the dais to felicitate our chairperson.
आप पहले आगे आ जाए करो टाइम बचेगा. I request.
Sir.
Please felicitate the chairperson.
Dr. Shigan and Dr. Nitin Devrukar are the winners for the lucky day.
I request somebody from the managing committee to call Dr. Suman Pandya and Dr. Chetan Awala this side because they are the chairpersons for the lecture. Can somebody please help me out with this? Pendekar sir, please आप जाके इनको बुला कर लाइए. Pandya sir, Kiran Awali sir, where are you? To start with the next lecture, we have just read the lecture. Dr. Harish Kata wants to give early. So, Harish sir, आपके लिए दो लाइन. सेफ हो या डॉक्टर, पेशेंट हो या डॉक्टर, अगर उसका बड़ा है पेट, सोता है लेट, एक्सरसाइज नहीं करता, जंक फूड से भरी रहती है खाने की प्लेट, तो एक दिन करोड़ारी आंटी कहती है
रुकावट के लिए है खेल. डॉक्टर अमृत मेहता बताएं कि रिसेंट अपडेट्स.
सर बहुत प्यारा लगा.
वेलकम डॉक्टर.
बना नजर लग जाएगा. थैंक यू.
Welcome Dr. Harish sir. He holds an MBBS from JS Medical College. Sir, very great sir. Then sir.
Sir, आपका introduction करेंगे. So we have with us Dr. Suman Pandya sir, who was our president twice in the past, founder member of Mdmpa, very efficient, hardworking, soft-spoken. and is practicing in Dharavi for last more than 40 years. And to accompany him, we have Dr. Kiran Awali, who is our past editor, young, dashing, energetic, and has all new ideas, a gentleman who works behind the curtains, and my colleague.
Thank you, sir.
Thank you. I've been to Mind Dharavik 20 years, so I think everyone knows.
Yes.
So I'm not going to speak today. Because I feel that new kids on the block should get a chance. So I have a new team member, Dr. Mdmpa. He's a consulting interventional cardiologist with us at Raja and Mundja Hospital. He's coming from MG Mumbai.
दिल्ली डॉक्टर का दिल्ली बहुत बड़ा है.
And he did his cardiology from KFC Manipal with a gold medal. Over to Raghav.
Good morning. We're talking about the art of complex coronary interventions. So this is old images from the 1970s when the coronary angiography and angioplasty initially started and how it was done at that point of time. This is a historical perspective of how coronary interventions have evolved over the last 5 decades, starting with the first balloon angioplasty era in the 1970s to the development of bare metal stents that were being used before. And then subsequently we had shifted to drug-eluting stents that came in the first generation drug-eluting stents came in the early 2000s. Then we had the second generation drug-eluting stents in 2010, 2015. And then we had the latest generation stents. We also had bioresorbable scaffolds, which initially 1 decade back, they were the latest things, but then they were withdrawn from the market because of high risk of stent thrombosis. But now we have the next generation bioresorbable scaffolds, which have been introduced and under trials. And also we have drug-eluting balloons, which is a new. This is a different stents that are available, different type of the current generation stents. So we are commonly using. We have durable polymer coated stents, we have biodegradable polymer coated stents, which is the latest generation. So and we have polymer free drug-eluting stents, and we have the bioresorbable stents. So this is the bioresorbable scaffold. So the concept for the scaffold was that the stent will get absorbed. It's a self-resorbing stent. So you do the angioplasty, you open the vessel, and the stent will get dissolved in a year or 2 years. But the initial first generation, the thickness of the stent was more, so they were higher. Long-term outcomes were not optimal, so it was withdrawn. But now we have the second generation stents, which are being increasingly used in Europe and under clinical trials at various centers. So they are showing promising results. We have the NLS 100, which is available in India also. So this is 100 microns, which is a thinner stent. But still long-term data needs to be available. Also, we have drug-coated balloons, which are primarily either paclitaxel or sirolimus coated. So what we are moving towards is a hybrid strategy for coronary revascularization. Idea is to achieve complete revascularization, and long-term we don't want in-stent stenosis, we don't want new lesions, we don't want bifurcation, side branch compromises. So this is part of that hybrid strategy toolbox. One of the modalities is drug-coated balloons. Initially, it was being used for in-stent stenosis lesions, small vessels of 2 to 2.5 mm, longer lesions, bifurcation lesions, and CTOs. So currently, and especially it becomes more relevant in patients with diabetes, in patients with high bleeding risk. So high bleeding risk patients are less likely to tolerate high dose of antiplatelets post PCI, which will usually be required with the stents, if you do conventional stent. Also, patients with diabetes, as we know, are higher risk of new lesions, restenosis. So usually the strategy we follow is during the angioplasty, post lesion preparation, once we do the initial balloon dilation, plaque modification, So if the result is optimal, we can do a drug-coated balloon. In some scenarios where primarily DCT is planned, we may still need to switch the strategy intra-procedure to a drug-eluting stent if there is a dissection or if the plaque, there is a recoil in the vessel, the luminal gain in the vessel is not optimal. So those are the scenarios where we switch, otherwise DCT can be done upfront. So this is a recent study published in 2024 JAC Asia, which showed complex lesions PCI with DEB-only PCI versus DCB based, that is drug-coated balloon versus the conventional stent. So it found that more or less, as we can see over here, the risk of target vessel failure was same except in bifurcation lesions. So in bifurcation lesions, it gives a much better result if we use a hybrid strategy or if we use drug-coated balloon, because it prevents restenosis at the side branch ostium. Another important modality in PCI is intravascular imaging. It helps us understand what is the type of the blockage that is there in the artery, what is the vessel size, what is the calcium distribution, what is the thrombus burden. Also during PCI, how is the stent expansion, so we can assess how, we can see using these modalities how the vessel looks from inside in simple terms. So we have two common systems. One, we have the OCT, which you can see on the right hand side. These are a few images showing the intravascular imaging of OCT, which is optical coherence tomography. And we have intravascular ultrasound iris, which we are using for most of our cases are imaged right now as per its class 1 indication for all complex PCIs. So on the left hand side you can see the intravascular ultrasound images. So apart from PCI, so usually we do intravascular runs in 3 things. So before we do the angioplasty, we give a 3 PCI run to assess the plaque, what is the type of the blockage, because blockage is of, there are a lot of phenotypes to that blockage. So we need to understand how to approach it and what are additional tools will be required. So to plan. Second is we can assess how the stent has expanded once we deploy the stent, whether there is any malpositions, stent edge dissection, any residual diseases there or not. And also for follow-up cases, long-term, if the patient comes back, we decide to do a check and we can always, it's advisable to use imaging to reassess what is the mechanism of the new blockage and whether there is stent expansion or any stent fracture is there, late stent malappositions have developed, or it's new atherosclerosis or new multiple hypoplasia. So these are the, it's important to identify this because the treatment approach changes. Also, one other important aspect to PCI is physiologic assessment. We all want to know whether is the lesion significant and will it benefit the patient long term, doing angioplasty or opening that block. All blocks need not be treated with a stent. Also, assessment, so primarily we look at the angiography, we see what is the percentage of the blockage. If it's more than 70%, we usually would favor PCI. Less than 70%, we try to manage medically. But a lot of patients may have borderline lesions where angiographically it may not be very clear. So you want to have a more objective method of assessment where you know exactly what is the functional status of that stenosis and will it benefit doing PCI. So there are various modalities. A lot of new softwares have come in, a lot of new technologies have come in the last 5 years. We also have from initially now CT scan started with CT calcium score and then CT coronary angiography, where CT CAG, which was being done as a screening tool, when patients who are doubtful, you don't want to do invasive upfront. So we also now have CT derived FFRs, which will tell us not only the stenosis on the CT scan, the percentage of stenosis, but also whether it is functionally significant or not. So you don't have to. So this is one modality. And in the cath lab, there are of course the FFR we have been using since many years. We have other parameters, IFR, which has come in recently. We have we also, so these require special wires where we need to put a wire across the lesion and measure the pressure gradient. So what we are doing is measuring the pressure gradient, distal pressure gradient and the proximal, and seeing how much it is dropping. So that will tell us how much is the functional significance of that stenosis. So we also have newer softwares with angiography derived FFRs. So we don't have to put that special wire also only with the angiography when we are doing it. The software analyzes the flow and it tells us, whether it is significant or not. So complex PCI. What do we call complex PCI? So what is, because some angioplasties will be simple, some lesions are simple, very straightforward, and some are complex. So usually complex is when you're dealing with a bifurcation requiring 2 stents, so because the complexity of the procedure goes up. Total stent length requirement is more than 60 mm. More than 3 lesions, we are treating multi-vessel disease, multi-vessel PCI. We are treating a CTU, that is chronic total occlusions. So that falls under complex PCI. Because not only, because it's important to understand, because it tells us the prognosis, long-term prognosis we want to know. We want to know the risk, procedure risk, the patient wants to know, and the percentage probability of success. And so, highly calcific lesions requiring use of rotation atherectomy, rotor ablation, IVL, these modalities, heavy complex burden lesions with a lot of clots inside the arteries. And vein bypass graft PCI. So a lot of patients who initially went for CVBG, they would have arterial, they will have a mix of arterial and venous grafts. So venous grafts have a higher probability of failing over maybe 10 to 15 years in some patients. Then they will come back with the ischemia, with angina, do a check angio. So they would require a vein graft PCI. That is another thing. And so complexity in PCI depends on the anatomy, the type of the disease, whether it's a diffuse disease or it's a focal disease. So focal disease is obviously simpler to treat. You have a diffuse vessel disease, it becomes more challenging. Depends on the degree of calcification. So some patients have a phenotype which is heavily calcific, and that is more common in diabetic patients, CKD patients on dialysis or not dialysis, stage 3, stage 4. So when they come to us, they have a very calcific coronary artery disease. So also the distal, how the distal vessels, what is the tortuosity in the vessels, whether the vessels are straight, whether the tortuosity is the angulations. So some anatomic components to understand this. Also, other aspect is obviously the functional status of the patient, comorbidities, what is the age, what is the frailty, how is the patient physically, whether COPD, diabetes, all the conventional comorbidities that we are aware of. So they all play a role in assessing the risk for PCI, assessing risk also for surgery, whether the patient is fit for CVG also or not. Because some patients with a very complex disease, medically they may be CVG may be the first option, but they may not be fit for a surgery. So you don't have, you have to do PCI for them because you have to save them. Right? Also coexisting valvular disease. With our increasing aging population, we are having this valvular plus coronary mix. For patients who have both diseases together, it becomes more challenging to treat this population. Also, how the patient presents is very important. The PCI depends on whether it's a chronic stable angina, whether it's an acute coronary syndrome scenario. Because management, a lot of things change with that. Hemodynamic status, whether the patient is in cryogenic shock, what is the pumping capacity. So that's why EF is very important. We all look at echoes, we all see the EF, we all write it. So because it is very important parameter, it tells us how well the procedure, patient will tolerate the procedure, it tells us the long-term outcome. And also, clinical condition, acute kidney injury or sepsis, ACS scenarios. So these are all high-risk conditions. It's usually will favor in these scenarios because most of these patients will actually be unfit for surgery. So what is protectivity, PCI? So in patients which we feel are unlikely to tolerate, because during PCI also there is going to be hemodynamic stress on the heart. We want to know how well the patient will be able to tolerate that procedure. So in patients who we feel are at high risk of hemodynamic compromise during the angioplasty, we go for a strategy of protective PCI. We use a mechanical circulatory support upfront. to stabilize the patient for the duration of the plasty, and then he goes off the support once the plasty is done. Then we give time for heart to recover. So usually single vessel disease, the last surviving coronary artery, that is the kind of disease, where there is only one coronary artery, you have to do PCI to that. So the entire heart circulation is dependent on that artery. Suppose the other part is a block. So when you are doing PCI to that, you will compromise flow to that segment of, so the entire heart circulation is at risk. So, that is the kind of conditions we will need protected PCI in support of IUDs, impellers, which I will be discussing. And of course, left dominant circulations, complex bifurcation, left main lesions, these are the scenarios. And comorbidities, of course, as we have discussed. So these are the MCS, mechanical circulatory support devices, which are commonly used. IABP has been there for a very long time. You know the mechanism, it helps to. So it basically works on balloon inflation, deflation, it synchronizes with the heart rhythm, and it helps to support the cardiac output. That is IABP. But we have a better device now, Mdmpa. So the amount of cardiac output they increase is different for these devices. So the amount of support they provide is different. So this is an increasing order of support. So IABP is lesser support. When you, some cases you need more support. So you have Mdmpa, which we are commonly using now for almost all of the high risk chip cases, such as complex protected PCI cases. And it works very well. We will be discussing a case. Then we have tandem heart. And we have final option is VA ECMO. Hemodynamic collapse patients, you want to do PCI, ACS, shock, papillary muscle rupture, severe MR, all these kind of scenarios, VA ECMO may be life-saving. Because it gives you the time to stabilize the patient and to do PCI. So you reverse the cause and then you try to reverse the pathology. This is a lot of algorithms for treating different type of complex PCI scenarios. This is one of the things we look at for calcium, because calcium is very common. If you want to assess angiographically the degree of calcium distribution, you grade it mild, moderate, severe, then you decide the strategy of how you want to tackle it. So we have a lot of, which will be discussing calcium modification tools, which are being increasingly used nowadays. So we decide, we have high pressure balloons, cutting balloons, or for moderate or severe calcium, we want to go to IEL, that is intravascular lithotripsy. And then you have rotational or bilateral you have lasers. So for calcium, of course, IOS OCT assessment will help us to know these are the tools for managing coronary calcified lesions. You have non-compliant balloons, the first step. This is all again increasing order of severity. Then you have cutting balloons, which help to cut the plaque. You have ankle scalp that also modifies. So these are all plaque modified devices. They cut the fibrous tissue with the plaque, they cut the calcium. So it gives the stent space to expand. So one of the very critical aspects for a successful PCI and long-term results is plaque modification, because that will decide how much the stent expands and how well it remains expanded, and whether there are new blockages will it come with the stent or not. So that's why so much focus in recent years on this. Then you have shockwave lithotripsy, which gives shocks of high energy ultrasound to break the calcium. You have lasers, we'll be discussing orbital electrophomy and rotational ablation. So this is like a drill. You drill into the artery. As you can see, this is a drill with various sizes. This is a machine you drill and you create a path in the coronary artery. This is the newer Mdmpa 360 orbital electrophomy system. It uses a centrifugal concept. So it also has a drill. It also has that tip which is similar to the rotavirus that we saw for rotational electrophomy. But it rotates instead of only the drill action, it also has a centrifugal circulatory action. So it cuts all the plaque in the artery. So this is the mechanism, this is the crown, and it rotates and it ablates the entire plaque. So you have shockwave balloon, which is lithotripsy. It helps to modify the plaque, break the heart tissue based on high energy pulses that the balloon delivers. This is the exact laser electrophomy. The various catheters, it works both on UV light plus sonic wave concept. So it integrates two types of energies, so helps to modify the plaque. Various catheter sizes are available that depends on the anatomy, what will be suitable. This is a recent review, ICR. So in situations where lasers will be very helpful, some of them are non-crossable lesions where you cannot cross the stenosis with the wire. What do you do in such scenario? So this is what is the bailout. This is what will help you with that. Non-crossable lesions, non-dilatable lesions, under-expanded stents, diffuse instant stenosis. Those special scenarios where it helps. Then we have the left main revascularization, which is the cornerstone of complex PCI. It's a bifurcation lesion and significant myocardial is at risk during PCI, and we want optimal long-term results. Initially, the problem with bifurcation lesion was the instant stenosis at side branch ostium. So the branch ostium, the stent will develop stenosis. So if this is not done properly, the patient will come back to you in 6 months, 1 year. Again with angina, and you go and you find that there is a big stenosis at that point. So do it properly. So this is about, again we do at heart team strategy, deciding between CABG versus PCI. It's a combined approach. We use physiology, intravascular imaging. This is again discussing various strategies, algorithms for this. We discuss a few cases. This is one of the first, this we can see left main bifurcation lesion, critical stenosis and left main. It's a left dominant circulation. So almost entire of the heart circulation is from this. It has critical almost 95% stenosis, both at hospital and hospital serve. So patient presented with ACS in the middle of the night, LV dysfunction, pulmonary edema. This is what we decided to do. So this is of course wiring. This is I'll skip through this fast. It's just more of how we do it. But we wire both the vessels. It's a difficult anatomy. A lot of these patients, if they were not present in ACS scenarios, will go for CABG. But in ACS, in acute setting, this is what helps. This is what is life-saving. This is when we do the kissing balloon, we open and you see the final result. This is report. These are all steps of that, and you see how quickly the vessel is open. This patient will be very well on 2 years of follow-up. This is another scenario, same ACS, LV dysfunction, diabetic hypertensive patient. You can see in this, in the last, say, we have a bifurcation lesion, we have L6 disease, this again left dominant circulation with a lot of calcium in this, so we had to do a rotablation, that is a drill to break the calcium, make the path, so that you will do a successful PCI. This is rotablating the LAD first, then the LCX, this is ideal. And then again, this is the final result.
Time up, sir.
This last. Since this is the final case, we're discussing EF of 25%. So this is the angiogram. You will see critical left main bifurcation disease. Very, you can see the calcium. It's a heavy calcific disease. So syntax score is more than 35. First choice would have been CABG. Other option is obviously checked with impeller support, because you need hemodynamic support for these kind of cases. So we decided to proceed with impeller supported PCI with rotablation to modify the plaque. This is showing the impeller insertion from the venous axis, femoral arterial axis. This is the challenge is because a lot of these patients will have calcifications even in the peripheral vessels. So aorta will also be calcified. The peripheral artery, iliac arteries, femoral arteries, all will have calcium stenosis. So the impeller could not go initially. So we had to put a 40 inch long sheet, and through that sheet then we were able to track the impeller. So this is how we track the impeller across the iliac bifurcation stenosis. So this is the impeller in the position in the LV. It takes over the, so impeller takes over the pumping function of the heart, so it supports the cardiac output during the procedure. Then we proceed with the rotablation. So you can see the drill moving forward. So this is rotablation the vessel. 180 RPM. Then again we proceed with the standard bifurcation strategy, DK crush. Then there's a stenting, this recross. These are all the steps. And this is the OCT. We used OCT to intravascular imaging. I was discussing to assess, the results, the areas that we are getting. And this is the final result. So anyways, that was the final result.
Thank you, डॉक्टर राघव, जो घाव लगा था हमारे दिल पे जब हरीश मेहता साहब ने मना किया, एक प्यारे से लेक्चर से आपने उस घाव को कर दिया. Thank you.
Thank you, sir.
The chairperson of the speaker, हरीश मेहता सर, आप भी प्लीज आइए. डॉक्टर हरीश मेहता सर, आपको मैंने कार्डियोलॉजी का बताया.
Now I request Dr. Archana Shinde and Dr. Nisita Chaudhary to come on the dais to felicitate our chairperson.
And also the winner of last year's conference, Best Speaker Award, Mdmpa Best Speaker Award, goes to Dr. Kaya. Dr. Kaya is not in India, so Dr. Harish Mehta is going to take that award on his behalf. Thank you, sir.
सर यहाँ पे आ जाओ. आगे
Dr. Haqiq Ahmad, Dr. Imran Sheikh.
आइए मैम. Thank you. It is said that the success of a cardiologist depends on the failure of the heart of a patient.
Lucky draw winners, Dr. Imran Sheikh and Dr. Haqiq Ahmad.
ऐसे ही newer medication and newer device का टॉपिक को लेकर आ रहे हैं डॉक्टर का पेशेंट. अंकुर अपने लेक्चर के साथ में मुझे एक और स्टैटिस्टिक्स देने वाले हैं. ईश्वर कॉलन हैंसन, कितने फीमेल पेशेंट ने आपको अपना दिल दिया है? ये स्टैटिस्टिक्स ज़्यादा इम्पोर्टेंट है सर. आपसे तो कम है सर.
I would like to call upon the dais our chairperson for this session, Dr. Milind Toraskar and Dr. Arvind Shah. Dr. Milind Toraskar, his motto of life is hungry for knowledge. None other than our past president and secretary and junior committee member, Dr. Milind Toraskar, practicing in Mahi since last 30 years. To accompany him, Dr. Arvind Kumar Shah is a homeopathic consultant practicing in Dharani since last 30 years. Welcome, sir.
The next 25 minutes is going to be an interactive session from Dr. Ankur, so everybody participate. Sir.
Thank you for your kind introduction, Dr. Naseem Khan. Dr. Ankur Fatalvekar is a proctor of Boston Scientific for Rotor Ablation. He has considerable experience doctoring young cardiologists and managing chronic total occlusions, bifurcation, stenting, left main interventions and rotor ablation. He is a proctor of optical coherence tomography for Abbott, one of the few people in the city to be certified as a proctor timing implanter for both balloon expandable and self-expandable valves. He has performed device closures of AHD, PDA and VHD, balloon procedures of aortic and pulmonary valve coaguloplasty, and he has expertise in permanent pacemakers, ICD implantations, and cardiac resynchronization therapy. He is a recipient of the Outstanding Young Person Award 2019 by Junior Chamber International JC. Please welcome Dr. Ankur.
Good morning, everyone. And I think it's my 8th or 9th year now in Mdmpa, and I'm every year coming and giving this lecture. It feels like home to me. I was given a mandate this time that I'm not going to show any angiography videos or anything. I'm going to speak about heart failure, and I'm going to speak about drugs, and I'm going to give you a message. So the talk is about newer drugs and newer devices, but I'm going to also talk about newer approach. So very simplified way, okay, to treat heart failure. Now, when I ask questions to, to lay people as well as doctors, what's the difference between heart attack, heart failure, cardiac arrest? Many times to my surprise, I'm not able to get the right answers of people. So to simplify it and to the obvious audience, heart attack is when you get a clot in your artery, the blood flow goes down, and the pumping of the heart goes down and the water fills with lungs, you get pulmonary edema, that's heart failure. And cardiac arrest is when your heart stops functioning and then you get an assisted, that's the cardiac arrest. Now today we're going to talk about heart failure. So you can see this slide. When you get hospitalizations, so continuously there is a decline. So once the patient gets hospitalized, it's a downward spiral. You can see it going down the hill. So every admission, the chances of you getting mortality or death increases when you have heart failure. And you can see in India, the incidence of heart failure is soaring. Why? It's because diabetes is increasing and people are living longer, and that's the reason why you're seeing heart failure both preserved as well as reduced. You know the difference between reduced is once your ejection fraction goes less than 40, and preserved is somewhere when your ejection fraction is more than 50. Between 40 to 50 is called mid-range. So you can get heart failure even with a normal ejection fraction. Why? If you have a severe LVH, the diastolic dysfunction sets in. You can have patients with hypertension, having pedal edema, breathlessness. We all see this, right? In our clinics, we see our patients see their feet is swollen. So heart failure can come with reduced ejection fraction. It can come with preserved ejection fraction as well. So you can see in India the prevalence is soaring. And you can see this 30%, that is almost 1 in 3 patients of heart failure get readmitted at least once a year. So these are all problematic statistics. And the mortality is also very high. Now 1/3 of these patients will have a mortality, which is there. Now, what is the therapy? We have Fantastic Four. So when you go home, I'm going to talk about Fantastic Four, Fabulous 5 and Super 6. Okay? So Super 6 is these 6 drugs which are now used for heart failure. Okay? This is for the drug part of it. And I'm going to talk about 2 devices as well. That is cardiac desynchronization therapy and a revolutionary therapy called as HeartMate 3. So what is Fantastic Four? So in 2013, 20 odd years, we had nothing to treat heart failure except for these 3 drugs. ARBs, you know, the telmisartans, the enalaprils, or that is the ACE inhibitors, that group. Okay. The second was beta blockers, and the third was MRI. Now, what happens in heart failure? The 3 systems, detrimental systems, go up in your body. One is the sympathetic nervous system. So you have beta blockers to block it. Then is the RAS system, the renin-aldosterone system. You have the ACE inhibitors to block it. And then you have the aldosterone system, which causes fibrosis in your heart. So you have the MRA, or the mineralocorticoid receptor antagonist. You know the lacilactone, the spironolactone we have, that's the MRA. So we had only 3 drugs till 2013 to treat heart failure to increase the longevity. Obviously we had Lasix and all these things to improve our symptoms. But as you know, Lasix just improves the symptoms. It doesn't do anything to the mortality of the patient. But then, Paradigm HF, this was a paradigm shift. Ernie came in, the sacubitril valsartan, Wynmeda, as you know the brand name, came in 2014, and I was a part of this trial. I was a lecturer in KEM. We had a blockbuster drug. Novartis came out with this blockbuster drug. 25 years we did not have anything. And then this came in, and this changed. And what it changed, you could see this. 20% benefit in primary composite outcome. That means the MACE events went down. The cardiovascular death went down by 20 odd %. And heart failure hospitalization went down. So, Ernie became a mainstay therapy, replacing the ACE inhibitor ARB. And you can see here the guidelines changed. And in 2016, the ESC and in the 2016 ACC, they changed that when the patient was on ACE inhibitor ARB, if there is a heart failure, you stop it and switch to ARB. So it's very important whenever you get heart failure patients, you have this drug added in your prescription. Now, after that came in the SGLT2. And sorry for missing my slides. Can we go behind 2 slides? 2 slides back. One more slide back. One more slide. Yeah. So DAPA HF trial. So dapagliflozin, as you know, all of us know, is a diabetic drug. But in non-diabetic heart failure, now it's the mainstay therapy. So your prescription, when you see ABCD, EFG, ARNI, beta blockers, MRA, and now dapagliflozin or empagliflozin. Very important. DAPA-HF was a trial, a heart failure trial. Even in non-diabetic patients with heart failure, when dapagliflozin was added, it showed over and above benefit. And you see, this was a landmark trial where it was significantly better, 16.3% in the primary outcome in the DAPA group versus non-DAPA group. So this became a mainstay therapy. So the fourth drug has to be in our prescription when you see a heart failure patient. How does it act? It acts by glycosuria action, osmotic diuresis, and diuresis. And also there is a switch in your myocardial cells from the glucose to ketones. And that leads to the improved cardiac ejection fraction and also cardiac hemodynamics. Now, it's not only important to have these four drugs, it is important to have these four drugs early. It's very, very important. I want to impress upon this. Patients who are in heart failure, when you start these drugs in the hospital, rather than when you see them outside in your clinic, there is a difference. There is a difference. You are adding days to their life. So this was the conventional sequencing. You step one, add an ACE inhibitor, ARB, now it's replaced by ARB, beta blockers, MRA, and then finally SGLT2. So this was the sequence. But now, what we do is the right side, the rapid sequencing. How do you start? You start with the beta blocker. Beta blocker has to be before you discharge the patient. Why? Because the chances of arrhythmias are high. When you beta block, the arrhythmia chances also go down. Plus SGLT2, that is dapagliflozin 10 mg. You have your Oxraj and dapagliflozin of the world which you start. Step 2 is you start the ARNI or the Mdmpa, and step 3 is the mineralocorticoid receptor antagonist. So this is the rapid sequencing which we start with. And you can see when you what is the difference between comprehensive therapy versus conventional therapy. You see 8.3 years, additional years that are added to the patient when you use these four drugs. That's huge, that's massive, right? And the success has been considerable. There is still more scope for improvement to add more and more days to our heart failure patients. Now the fantastic 4 is over. Now we go to the fabulous 5. What is the 5th drug? The 5th drug is vericiguat. Vericiguat is a guanine cyclase simulator, and that is one drug which has shown to have morbidity benefit. That means the patients have symptomatic improvement. The mortality benefit, the trials are still yet the jury is still out. But for symptomatic benefit, vericiguat is one more drug which needs to be added to your fantastic 4. And I've seen this, and the beauty of vericiguat is because with ARNI, you need to monitor your potassium. You need to have blood pressures maintained because it causes fall of blood pressure. The beauty with this is if your GFR is more than 15 and your blood pressures are even low on the lower side, you will start this without bothering. So you start with 2.5 OD and go to 10 mg OD. So that's the dose of vericiguat. And what do the guidelines tell you? It's still 2B because the evidence is still coming. But my firm belief is this drug in years to come will be right up there with these 4 drugs. Last is IV iron. You all love iron, right? I know iron is your favorite drug. I also love it, but I love it IV. Why? It's because you all know iron is a very poorly absorbed drug. You give it to calcium with milk, only after 100 mg, 10 to 20 mg will get absorbed. In heart failure, it's even worse because you have gut edema also, so the absorption is even lesser. And I find the referring doctors, the treating physicians sending to me, asking me, the hemoglobin is normal, why the hell do you want to give iron, right? All of us will know iron deficiency, the last to fall is hemoglobin. So iron deficiency sets in much early. So iron is a drug, it's a heart failure drug, and what I've seen is immediately after I've given exchange to patients, injectable, the improvement is dramatic. It's as dramatic as I've seen with ARNI. When I started Mdmpa, I still remember an old man telling me that he had to do his Aarti and he could not tell his Aarti because of heart failure. And when Mdmpa was started, he could tell the entire thing in one go. That was the difference which I saw when I started ARNI in patients. Similar benefit I see when I start HCM in patients. And all of us should know that along with that iron, in routine patients also, this is my advice, along with the hemoglobin and CBC, make it a point to do iron studies. Very, very important. You just don't go upon the hemoglobin levels. And the guidelines are also changed. So, if you have any ferritin levels which is less than 100 or between 100 to 300, you see the TSAT, that is the transient saturation. And if it's less than 20, it's an indication to do IVI in heart failure. So all of us, our patient, ये तो मेरा hemoglobin इतना ही रहता है, right? 10 ही रहता है, 9 ही रहता है, 11 ही रहता है. Give my receptionist, she had iron of hemoglobin of 8 and chronic anemia was going on. One shot of FCR and her hemoglobin was 13. And the appetite improves, the general feeling of well-being improved. So this is a heart failure. The Super 6 also comes in, and this is what I want to impress upon. This is the take-home slide of mine for drugs. Okay, before I go to devices. Step 1, rapid sequencing. Ernie, beta blockers, MRI, SGLT2, and Veraciguat. Why green and yellow? Green is mortality benefit. I'm adding days to life. Veraciguat is, life 2 days. जितना जिएगा अच्छे से जिएगा, morbidity benefit, and IV iron. So when I start, the minimum of this is a beta blocker and SGLT2 has to go before the patient goes. And what I've seen now is a lot of digital apps coming in. So Lupin Digital also has this digital app, which the Symbiosis Hospital now, which is actually Symbiosis, they have changed the brand. So has a trial which is going on. So heart failure patients, we are giving digital monitoring to the patients, a glucometer, BP apparatus, a cardiac nurse going. The monitoring is so better and the patient feels so better and the outcomes are better when they are monitored. So digital monitoring is very important in heart failure patients with the newer medical devices which are there. We should do a lecture on how to use medical devices. How to use this watch is also not on most of the people. Right? So heart failure and newer devices. Now I'm going to talk about 2 devices. Cardiac resynchronization therapy. Now watch this video. I want you to see this video. When the heart, the ejection fraction goes down, you see how the heart dilates. You can see the size going on bigger and bigger. And once that happens, it takes more time for the electric current to go across to the ventricles. You can see this, you can see the broad ECG complex there. The QRS duration is so broad. It takes time for your heart to, from the right to flow to the left in the left bundle branch block. And what happens? The right heart contracts first and then the left heart contracts. And because of that dysynchrony, the ejection fraction drops down, the LV becomes more dilated. So you can see this delayed left ventricular activation, paradoxical septal motion, mitral regurgitation also comes in because heart becomes like a football. Right? And therefore the valve goes separate and there is a central leak which keeps on happening. And this again begets, because there's MR, the heart becomes even more dilated. Now what do you do in a cardiac synchronization therapy? You put 2 leads, one in the right ventricle, one in the left ventricle, and the RA is placed if you have pacemaker indication. What it does is simultaneously gives current to both the ventricles at one go. You can see that in this video. So this thing really see, you can see the right side contracting first. Now when you see the electric current, they are simultaneously contracting. You see that? When that happens, the LV gets narrowed, the LV dimensions go narrow, and the ejection fraction improves. You can there are super responders. So the first CIT I did was in KU hospital. That patient ejection fraction improved from 10% to 60%. You need to have a left bundle branch block on the ECG for doing this. So any left bundle branch block on the ECG, non-stupid PCMP, ejection fraction low, CIT is a device which has to be offered to all our patients. This is how you do it. You can see one lead which is going right across, that's in the left ventricle to the coronary sinus. This is the RV lead and that's the right atrial lead. So RV and LV contract at the same time. Now what I want to show you is HeartMate 3. HeartMate 3 is like destination therapy. So it's a left ventricle assist device. The beauty of this is if you have a heart failure patient, you can attach this pump to the heart. You can see the inflow part is there in the left ventricle and the outflow part is there in the aorta. This is like a heart which is battery operated. Okay? You can have this magnetic levitator which is there. So it's because it's magnetic, there are no bearings, there is no hemolysis which is occurring. You can see it's moving, how it's moving. So it moves like a motor and pumps, it can pump as much as 10 liters per minute. So it is attached, one part is attached to the ventricle, one part is attached to the aorta. So when the heart fails, ejection fraction is low, this pump moves and pumps it through the circulation, maintaining the circulation. It is so beautiful that patients who don't get a heart for a heart transplant, they can put this, go about doing their daily activities. It's battery operated. See the batteries are there, the pouch they can be there. They go swimming, they do all the activities possible. So this is a revolutionary therapy. This is not science fiction. This is happening in Mumbai. So when a patient with recurrent heart failure, they're not getting a heart, HeartMate 3 is one thing which can be offered to our patient. This is a revolutionary therapy. We all should be knowing about this. We all should. Once the battery gets over, there are 2 battery lines. Battery gets over, you put a new battery. Okay, it's like charging your heart. So that's, I want to conclude, I think I'm before time.
Thank you, sir.
So I want to conclude, Fantastic Four, which I told you. There is a fifth one, Veraciguat, which is coming in new kid in the block, and personally I feel it's a fantastic drug. The sixth one is FCM, okay? That is Ferrous rapid sequence therapy, which I said, add all the 4 drugs, at least in low doses, and escalate it before the patient is out of the hospital. Early upfront Veraciguat should be offered to the patient. IVIS should be administered. Newer devices like CRT and HeartMate are there to reduce heart failure admission. This is our hospital, Symbiosys Hospital. Now we changed the branding. We have made it heart and muscular specialty. So we have HTS Symbiosys at Dadar, HTS at Ghatkopar. Now Ghatkopar Hospital is working very well with all your help and support and good wishes. And now soon we'll be coming in Boroni with our third setup. Thank you.
Super. I'm very sure डॉक्टर पतंग का एग्जाम पे अटेंशन पे लिया होगा अगर आपने तो बहुत सारे टेक होम मैसेजेस मिले होंगे आई रिक्वेस्ट द क्राउड स्टैंडिंग ओवेशन का बनता है request chairpersons to participate the speaker of the day.
Now I request Dr. Mdmpa and Dr. Pankaj Chaudhary to come on the dais to felicitate our chairperson.
Sir, थोड़ा आगे सर, आगे स्क्रीन से आगे.
This session second round, preliminary, Dr. Armstrong and Dr. Pallavi.
Cost of therapy. Cost of therapy.
No questions. Sir, cost of therapy.
Sir, HeartMate is 1 CS.
Really heart failure. 1 CS होते हैं, really heart failure.
सर एक मिनट. में 80 साल का है. There is a population now which is there. I'm not saying it very well, but there is a population 80 साल का है. जिसके पास जमीन पड़ी है, इसके पास पड़ा है. Once year आज के दिन में मुंबई के लिए बताओ. अगर not spend it on his heart rather than dying heart, I think he might immediately give him the option.
Not bad, definitely. सर पेशेंट बोलेगा दिल दिया है, पैसा भी तो मेरे देंगे साहब. केबीसी का 15 आंसर देंगे तब जाके 1 करोड़ मिलता है. Dialysis versus kidney transplant.
The patient is in tears and full of fears.
क्या करें और क्या न करें, पेशेंट डिसीजन लेने से करें.
के पेशेंट की ऐसी परेशानी को सॉल्व करेंगे आज डॉक्टर सिद्धार्थ पठानी.
प्लीज वेलकम डॉक्टर.
I would like to call upon the dais our chairperson for this session, Dr. Praveen Gujarati and Dr. Janvi Khawde. Dr. Praveen Gujarati, pathologist, started his journey as a pathologist on 11 June 1980 on his birthday, practicing last 45 years and on the medical committee since it is last 40 years. Good sir. He has worked in our capacity like president, secretary, treasurer, and almost last 35 years as treasurer. Man behind the singular idea of stage, backdrop, with annual medical conferences, and doing the work almost 33 conferences. Today's backdrop is also his brainchild. Has successfully accumulated 1.5 crore in RPT. I would like to introduce to one of our dynamic ladies, Dr. Janvi Khawde, who was Honorary Secretary for the last 203 years, now Vice President camp. She is practicing in Dhara since last 18 years and our most hard-working committee member. Welcome, ma'am.
Janvi, please introduce the speaker.
Thank you, sir. I would like to very pleasant good morning, sir. Dr. Siddharth Ganani presently practicing in central suburbs of Mumbai with his clinic located at Prabhavani and October. He is extremely skilled at managing all kidney diseases like acute and chronic kidney diseases, dialysis expert, interventional nephrology procedure like biopsy, temporary pulmonary dialysis catheter. He is a director at Kathani Kidney Care, consultant nephrologist and transplant physician at Fortis Revela, Global, Critical Asia, Justo, Wokan, Zainaba. Today's topic is dialysis versus kidney transplant in CKD management. How do I decide? Extremely interesting topic. Thank you.
Good morning to all. I think we've been listening to a lot of things. And so I'll be starting on something, of course, to kidneys, like we heard about heart, a lot of new things which are coming up. Unfortunately, kidneys, nothing much new coming, but at least we have a lot of innovations in what is going on already. So we will be going there. Most of the times, we keep on hearing on CKD, chronic kidney disease, what do we do, medically what do we do, when do we refer, what are the other possibilities. So now we go one step ahead. As I said, probably now, I think this is the 5th consecutive year where I've been talking, so to keep it interesting and crisp. So dialysis versus transplant. So whenever a kidney patient who is probably young, GFR is less than 20, the thought process comes, what should be there, how should we go about it, whether we should go on for dialysis, whether survival is better on dialysis or transplant. With the same probably, so we have started this dialysis chain now, so where we have 3 centers already functioning. So this is Ghatkopar, where we are probably trying to get the state-of-the-art facilities outside the hospital. So we have a 20-bedded at Ghatkopar, we have Kurla, and we have Ghatkopar East. So we have 3 centers at present. Soon we are coming at Sayan, Dadar, and probably Vikrul. So this is our first patient, just to probably have it a go. So what is CKD? Important part. So whenever we CKD, as all of us know, I'll just brush through some things. It is not only rise in creatinine, it is basically any abnormal structure or function. So structure can be right from solitary kidney to a horseshoe kidney to an absent kidney, probably or to a malformed kidney. Everything goes into the structure. And function is of course GFR or a creatinine value which is higher or a GFR which is lower for more than 3 months. That is when you label that patient as chronic kidney disease. Now, many times the question is whether only structural problem comes into the kidney. No, if you are having long-term proteinuria, if you are having persistent RBCs, if you have proximal or distal tubular diseases, if you have, as I said, imaging or probably problems related to the structure of kidney and GFR. So that is how you define CKD. So someone who comes with creatinine 1 always may not be a normal or a mono person unless proven. So you need to know that. Coming towards dialysis versus transplant to the topic today. So it is important to know multiple guidelines which says when do I start dialysis. So very important question. It is not the lab values which decide when do I start. Many times if you see the foreign literature, very clearly it mentions anything GFR less than 20, the patient should be offered dialysis. In Indian scenario, we are not able to do it because of economic constraints. Everything in outside probably world is sponsored or under the claim. In India, we still don't have that much amount of Medicaid to cover. So we wait or we go for probably some more conservative approach. So all signs of CKD, so acid-base abnormalities, excessive pruritus, volume overload, high blood pressure, poor nutritional or weight loss persistent even after weight, and of course the severe signs like uremic pericarditis, uremic encephalitis, and of course persistent recurrent hyperkalemia or metabolic acidosis. This is when you will start thinking that patient will need dialysis. So first important point, when should I think of dialysis? Now when a patient comes to you for dialysis, again 2 options to be offered, a hemo versus a peritoneal dialysis. So 2 important aspects of dialysis. In hemo, I go through how things have evolved over time. Second, when do I go for transplant? So any patient probably who is less than GFR 20 or there is an evidence of progressive and irreversible CKD over preceding 6 to 12 months. So we have started doing a lot of preemptive transplant. Last year we did 6 transplants. These patients slowly progressed with creatinine and without undergoing dialysis we could probably let them undergo transplant. Because this way on chronic follow-ups, once we realize that there is over 6 months their creatinine is slowly progressing, they were opted for transplant and before undergoing dialysis they could undergo transplant. So that is something called as preemptive transplant. Again, an important part, many times you see younger patients, they will not want to go on dialysis. Of course, a very good option for them that they will never see what is pain of dialysis and they straight away go to transplant. Now when I see dialysis, two things very important. What are the types of dialysis? I have something called as peritoneal dialysis, I have something called as hemodialysis. This is what a peritoneal dialysis catheter looks like. Again, important, lot of myths on peritoneal dialysis. कि बराबर नहीं है, infection होता है. Yes, you will have to have a caretaker always to do things. That is important part. And then this is how the peritoneal dialysis is taken care of. You have a peritoneal dialysis catheter inside, which I showed you in the previous image. That is connected to a bag, and this bag is drained out in the peritoneal cavity for 4 to 6 hours. At the end of 4 to 6 hours, you do a drainage. So this can be done manually and can be done automated. So a lot of time questions. If you see good probably population with long term now insurance is being high, slowly the option to the government is to include this form into the insurance. Yet this is not included in the insurance. Now as I said, CAPD is manual exchanges which you do, where a patient will do 4 exchanges in a day. So that will be manually, the water will be drained in the bag. It will take about 30 minutes for the bag to drain out. You can roam around for 4 to 5 hours. At the end of 4 to 5 hours, you will have to empty the peritoneal cavity and you can put a newer bag. So that is how a CAPD or a manual exchange is done. Then you have something called as APD. APD means automated. I am on a higher version of my thing. I don't want to do any manual exchanges. Many times you will not have relatives this time. This probably now with time you see a lot of relatives who are, their sons and daughters are in US or probably outside countries. They are alone here, they cannot do. So this is again a very good modality. Let the patient sleep on their own bed. You have a small machine, I will show you in the next image. It is kept next to the patient. Whenever patient sleeps overnight, the dialysis is done. By the time the patient is in the morning up, the dialysis is over. So no pains, nothing, no other requirement, only you have to connect the dialysis circuit to the catheter. So this is how a PD catheter, automated PD looks. You attach 2 bags and a cassette and the end of the bag is connected to the catheter. The volume is set according to the patient's requirement, and by the time over 8 to 10 hours patient, probably you can put it at 9 o'clock in the morning, and by the time patient is 7 or 8 in the morning, patient is done with the dialysis. Best part, you do it daily, so you are free to eat whatever amount of food you want. You are liberal on more water intake, you are liberal on more salt intake. So you have a better quality of life because you are doing it daily and not getting worried whether aaj mera pani niklega nahi. So of course an important part of peritoneal dialysis, the automated treatment. Now we have the hemodialysis, as we rightly said, still probably for routine patients we will require something called as dialysis yet, not to go to PD. Dialysis, what all we require? We require, this is how a dialysis is done. Probably the blood goes to the dialyzer, you have a dialysis fluid which by a counter current mechanism changes all the solutes and the filtered blood is returned back to the patient. What all you require to do a good dialysis? You require either a graft, either a fistula or a pump catheter. So any of 3, you have to have any of 3 to do a good dialysis. Adequate flow, it's like buying a car but not having a good speed. So you will have to have a good quality dialysis by probably a good quality water and of course a good blood flow. So these 2 things will keep patient on a longer survival than patients who are probably not able to get good flow. Now in dialysis, we have gone one step further probably. We have something called as home dialysis and in-center dialysis. So again, a lot of patients don't want to go for peritoneal dialysis, suspecting that caretaker burden may be higher, the cost may be higher. We have something called as home dialysis, where a machine is probably placed at your home. So sick patients, elderly patients, patients who are probably like who said cardiac failure patients, malignancy patients, because of newer and newer therapies with collateral diseases, patients will want to live longer. And this will be better where I don't have to take my patient every now and then to the center, I put everything at home. We have dialysis nurse, we have dialysis doctors who goes home and takes care of them. Again, benefit part covered under insurance. So everything goes under your insurance scheme. So patients are happy to do it because they don't have to spend it from their pocket. They don't spend for ambulance costs, they don't have to go to the center, they can do it luxury at their home and they can work. So we have at present somewhere around 28 to 30 patients who are doing in Bombay with us home dialysis, and most of them are working. So that's the best part, and they can earn on their own. Now, how do I decide, as I said, coming towards the topic, whether I should go for dialysis or I should go for a transplant? Common question to all of us. Now, personal lifestyle, multiple things when you decide for transplant. Many times patient will want probably that they will want to travel all the time, they will want to have leisure activities, they will want probably that they should be able to work comfortably. Then of course, transplant versus dialysis, transplant will be a better option because you will not need to continue filtration. You can roam around, you can probably travel the world, you can swim, you can do what you want, gym with transplants. Dialysis also you can do, but there will be some limitations for you. Personal preferences, I may be elderly, I may be 55, 60, I will want that thing, I don't want anyone to give me kidney from my family, I want to continue dialysis. Now question is, when comparing dialysis versus transplant, with today's good quality dialysis, you can have a good survival for dialysis itself. So for patients, of course we don't say dialysis is the best choice, but when you are selecting second best choice, you are still not doing wrong. So you can still probably continue. Of course, medical suitability, malignancy, chronic diseases, heart failure, where they may not be a medical candidate to go for transplant. Again, dialysis will remain the best choice. Whether to probably do home versus center dialysis, that of course the patient and relatives can decide when they come to us for discussion. Now, what is a transplant? So, transplant basically is transplanting one kidney from either a living or a deceased donor into the body of other. Of course, whenever a patient has probably a declared chronic kidney disease, this will be the form of therapy offered. As I said, a preemptive transplant will be dialysis or a transplant without needing dialysis to a patient. So they don't even undergo fistula construction or a catheter. They are straightforward taken for transplant. So again, an important part. Now, it is very important to decide on patients, because if you are not able to understand that you are going to undergo transplant and not able to take your medicines on a routine go, chances of rejection will be very high, and these are the patients which will not want to undergo transplant. We want to keep them on dialysis. Now, transplant, as we show, probably, so it's a myth again. Many times the question is again and again asked, मेरे दोनों किडनी का क्या होगा? दोनों किडनी राम लखन अंदर रखी जाएगी और एक नया किडनी यहाँ पे बिठाया. So you have a new kidney which will be probably transplanted here, where you have the artery vein ligated to your external or internal iliac artery vein and the ureter to the bladder directly. Now, in again transplant, we have two options: a live versus a deceased donor. Live always better, faster. With probably the current time, we are able to do transplants as fast as 3 to 4 weeks. So a patient decides that I want to undergo transplant, within 3 to 4 weeks with all probable things, they can undergo transplant. So that's how the things have become much faster. Deceased donor, yes, a good option if you don't have a live donor. The survival on a deceased versus live donors are almost equivalent, but the waiting period, as we see in probably Mumbai at present, is much higher, somewhere between 3 to 4 weeks. Now, how I decide and why I decide for transplant? I get a more active life. I have complete freedom for dialysis. I can eat what I want. I don't have any restriction of food, fluid, or dietary restrictions. And of course, only thing I remember is I have to have my medicines on a routine time because I am a transplant patient. Because sometimes you may feel as normal as other patients and you may forget. So that's an important message which the patient has to be reminded every now and then, that probably you will have to continue your medicines lifelong. Now, as an option of kidney transplant, as I said, all patients with medical disease, when you see, may not be an ideal candidate for transplant. So it's very important to select what you are seeing for. A patient probably younger age, as I said, without any comorbidities will be the best. You don't have any other options. They have to be told that आपको transplant कराना ही है. All of us probably will agree, over the last 1 decade, we have started seeing more and more CKD patients or probably dialysis requiring patients who are less than 40. So out of total dialysis patients which at present I am catering to 12 centers, 15% patients are less than 40. So that's important, and out of them, less than 20 are somewhere around 3 to 4. So it's very important because the numbers are increasing and we are seeing a lot of young patients probably landing up to dialysis. So, and most of the times, only way to catch them is testing. So that is where you people come into a role. Simple nausea, vomiting, or poor appetite or weight loss also may be a sign. So be alert and prefer getting blood tests on and off of all the symptoms or all investigations whenever possible. So of course, willingness to undergo transplant should be the first thing. That's why that's very important. And willingness to take lifelong medicines. The question or the thought process to a patient which will they will come and ask you is transplant के बाद दवाई लेना जरूरी है क्या? Answer is yes. कब तक? जिंदा रहते कब तक? So they cannot stop the medicines under any circumstances. So that's an important part. Now going towards the survival rates, multiple studies over time have been done, and most of them have shown that of course transplant always does excellently well when compared to dialysis. I will go through some slides which will have some graphs which will show that overall transplant survival will always be better. If you see here, in first probably 1 year, the transplant survival may be equal to dialysis, but as you go ahead, the transplant survival is always better than dialysis. Similarly, over 10 years, if you see significantly better survival than for a patient who's on dialysis. Again, live transplant versus standard criteria, extended criteria, donor transplant or a dialysis. Again, if you see the live transplant with standard criteria does excellently well. Extended means you have a donor who's diabetic, you have a donor who's hypertensive, you have a borderline size or borderline creatinine donor, but you still accept because the patient is young. If you see again the survivals with this is significantly better when compared to dialysis. So that is an important thing. Now we have few studies which have shown that if aggressive home dialysis, so that is dialysis as good as 4 to 6 times a day, which is done in most of US or probably UK countries, can have a survival which could probably be as significant as for deceased donor transplant. So it's like if you wash your car or if you wash your anything on a day-to-day basis, the clearance will be more and survival will be more. So the better and better number of dialysis happens, the survival can significantly improve, and that has to be told in mind. That's where the concept of incremental dialysis or more and more number of sessions of dialysis will come. I said preemptive transplant, which is very probably we are encouraging more and more young patients probably who's detected into their CKDs between stage 3 and 5 to undergo a preemptive transplant whenever possible. So if they have a donor, we should go for this. This is definitely a better option for them to go. So thank you. I will not probably have a
Thank you. I thank you for Dr. Lakhani sir for such a wonderful lecture. I request the chairperson of to say something.
Thank you, Dr. Lakhani. He is my doctor. In fact, I am survived by Dr. Lakhani's efforts. In 2019, I was admitted in Raija for my kidney treatment, and he reversed my dialysis. In fact, the total official dialysis and third certificate had a reversal of dialysis, and he did that. Thank you.
Thank you, sir, for continuing the diet of pressure forever.
Yes,
Now I request Dr. Shankar Sarala and Dr. Shah to come on the dais to felicitate our chairperson.
Sir, come in, please. Sir,
Dr. Pallavi Remula, Dr. Akram Farooqi.
Yes. Thank you.
Dr. Pallavi Remula.
Thank you.
Sir.
नजदीक आ जाइए फटाफट निकलिए Thank you.
Thank you.
And now,
Thyroid, prostate, या हो varicose vein, ये ट्रीट करते हैं without pain.
डर है कि ये न करने लगे कार्डियोलॉजिस्ट का धंधा चौपट, कार्डियोलॉजिस्ट बहुत टेंशन देते हैं फोकट. प्लीज वेलकम डॉक्टर फोकट. And I would like to call upon as our chairperson Dr. Sunil Kamble sir and Dr. Pratna Pujari. Sunil Kamble sir, a known diabetologist from Mahim and Sayan area, is known as Mr. Perfectionist. He's a master of many conferences that we have held for Mahim Narrow Medical Practitioners Association. He's also the past president of our association and a very intelligent man. And to accompany him, this beautiful lady with us, Dr. Pratna Pujari, experienced physical therapist practicing in Mahim for more than 10 years, and she has won Mrs. India Asia title and Mrs. Most Pleasing Personality title. Welcome, ma'am. Please introduce yourself.
Welcome, sir. Dr. Bhavesh Popat, sir, is an interventional radiologist and vascular specialist. He is experienced senior faculty from KM Hospital and Tata Memorial Cancer Hospital, Mumbai. His achievements include being a pioneer in Indian Association, Indian Interventional Radiology with standardized protocol. He is the founder of the non-profit Mumbai Vascular Foundation for Vascular Awareness. He is the winner of Times Healthcare Leader Award 2021. So specializes in varicose veins, peripheral arterial disease, uterine fibroids, varicose, deep vein thrombosis, aortic aneurysm, liver tumor, prostatic artery embolization, chronic kidney disease, hepatic and portal venous interventions. Sir is affiliated to Selvi Hospital, Bhatia, SL Haneja, Symbiosis, Nanavati, Breach Candy, Wokhart, and ED Puja Hospital, Mumbai. Today's topic of presentation is clinical impact of interventional radiology, case-based discussion. The director is yours, sir.
Good morning. I think it's always a pleasure to come to Mahim Association and speak to you all. 2 points to make. I think very happy to not compete with the cardiologists but the partner with them. I think one thing you know that I work together on almost patients. So very happy to do that. And second, very happy to know that Siddhartha started 3 centers across. He's taken the mantle of creator. I'm sure he's going to grow up to 10 or probably more centers. Talking of that, I think we've taken one more step further. You know now we have a center in Nala, we have a center in Ghatkopar. Wanted to make an announcement. We are starting with the Borivali Center in next 4 or 5 months. So the sort of pace and the work is starting as I say right now. Somebody started doing the work right now. So it's always a pleasure to share positive news with you all. Now you all have seen me talk on a lot of vascular procedures, right from varicose to diabetic foot to prostates. I thought let me come and show the other aspect of my work. You always see the vascular side of me, and I show you the IR side of myself. And talking of this base, I show you an array of cases where in thoracic intervention, and you would have, and I probably do a lot of interventions in hepatobiliary, in thoracic, genitourinary as well as GI interventions. I'll show you the thoracic side today, and broadly they are divided into non-vascular and vascular. And you heard of patients having lesions across in lung, and typically the diagnosis starts with doing a simple percutaneous lung biopsy. I know most centers across the city do biopsies, right from scan centers to biopsies, right from radiologists do biopsy. And I'm going to show you a couple of things where an interventional radiologist is required and makes a good world of difference in taking those biopsies. And these are typical needles and coaxial systems. Simple parenchymal lesion biopsies like the ones which is close to hilum, very close to pulmonary arteries. Sometimes we are called in to take a look into that, or sometimes very simple lung biopsies like 0.8 mm, 0.6 mm, small nodules
which sometimes is very difficult for a diagnostic guys to target. We go ahead and target that. Lesions where they are very close to aorta, they are stuck to aorta in the thorax. We probably what we do is do hydrodissection there. We use the needle, inject normal saline and dissect the structures like with our normal interventions, create space and then take biopsy. Very good to that. Now this is this region somewhere. If you see here, all the vascular structures right from azylus vein, pulmonary branch to aorta to SVCs, are all major vessels around that, and you have a small lesion as small as that. And then what we will do is we will give saline, we will create path, and we create a path. This is the kind of path that is created to make sure that we allow the needle to pass and take the biopsy next to the aorta. So I think this is where a role of expert intervention radiology comes into the play, and we get sections like that. Now, in sub-centimeter, as I mentioned, sometimes even patients in semi-oblique or prone position will modify the position, again reach out to these small lesions and take access to that. I'm not going to show more of these. This is one thing I want to show which is very absolutely stuck to pericardium. These lesions like that, where there is a risk of injury, a risk of vascular injury, we can actively go ahead and do it with the confidence that we can even take care of the complications if at all they happen. Sometimes you have lesions in the lung which require surgical resection, and they are very small and the surgeon may not eventually find out. What we do is place a percutaneous wire in that so that when they go for surgery, they actually have access and they can remove and do the resection based on that. I think these rest of the things, take pleural effusions and all that, I'm going to show you, but actually something called as Flurex catheter. This is what we are doing regularly now with malignant pleural effusions. No, with malignancies growing, some patients keep on requiring malignant tapping of pleural effusions off and on regularly, at least twice a week. Now in these patients, the way we do perm cats for dialysis, indwelling catheter, what we do is indwelling subcutaneous tunnel within the chest wall like that, and introduce a catheter. Patients can walk home without any bag. They are given this vacuum bags at home. They can attach the vacuum bags and actually do pleural tapping on their own. They don't require to go to hospitals on a regular basis. So this is how the dressing looks like, and these bags are given to them and they can do the tapping on their own. Now, a lot of these thoracic interventions, basically when you have patients who undergo a lot of major surgeries, thoracic surgeries like CABGs. Now you undergo CABGs, and a lot of times you would have heard that patients developing Tylus pleural effusion after that. You tap, you get white fluid. Now, earlier days, what would require to do is surgeon would require to open loop thoracotomy all over again, go and dilate the thoracic duct from which it is leaking. Now, what we do is with intervention, we puncture the lymph node, inject the dye, and we demonstrate that the cisterna thyroid and thoracic duct which is dilated, we go ahead and perforate. Mind you, this is how the lymph node is punctured. These lymphatic radicals that come out of that ducts, they are 2 mm, 3 mm in size. They are very thin. We go ahead, demonstrate, we puncture that, and we go ahead and embolize that with coil. So we can do that now regularly, and we are doing it very often. In fact, if you can't puncture percutaneously, what we do is we come from the venous side, and I don't know whether you remember from the brachiocephalic vein, the subclavian and the IgA junction, the lymphatic duct enters. Remember, these ducts are actually 3 mm in size. We can calibrate them, go ahead, put it in again, embolize and block the thoracic duct which is leaking. This is all largely diagnostic and supplemental. I think we are growing our role in cancer care and tumor treatments as well. One of the areas basically growing is percutaneous ablations, either by using radiofrequency ablation, microwave ablation, or cryoablation. And I'll show you what the basic principle is that it's basically radiofrequency ablation will cause ionic agitation, cause alternating current, and generate heat, and eventually cause apoptosis of the tumor cells. And typically when you have tumors which are less than 3 centimeters, these have a fantastic role in patient care. And this is how the needle looks like when you insert, and this is how the entire system looks like, the generator, the RF generator, as well as the needle and emitter. Typically in lung as well as in liver, in a region like that, emitter open the antenna and actually burn the entire tumor. That can be done for small RCCs as well. Lung mets, remember patients who undergo undergone colorectal surgeries and a solidly oligometastatic lesion in lung, then you need not go ahead and do surgery. This can be actually ablated with the help of radiofrequency ablation or cryoablation, which is the latest tool, and I'll show you some of that. Typically, if you want to see the data, when you compare it with surgical resection, you have a large beta analysis. If you see, even in liver lesions within 3 to 5 centimeters, RFA surgical resection is similar outcome, and that's why this is all published recently. Again, same outcome in terms of long-term results as well. When you have big lesions, big tumors, these probes have cooling mechanisms within that. Remember, one of the biggest beneficiaries of growing technology and AI is the field of information technology and data. It's a lot of benefit. New techs keep on coming every now and then. And I'll show you, apart from that, something like a microwave ablation. Now that's available. Now typically when we have tumor which was crossing very close to a blood vessel, like here, a part of the tumor may not get adequately heated up because the vessel is causing the cooling around the tumor. Microwave ablation will remove that, so that risk of not entirely heating up goes away. And it's again a needle like that, like a biopsy needle. You enter and eventually you burn the tumor with microwave ablation as well. The latest in ablation is the cryoablation, where instead of heating and burning the tumor, we freeze the tumor and cause ice wall within the tumor. I'll show you one example. Likewise, where in patients, you puncture the tumor with the help of this needle. Remember, this is again a 17 gauge needle, quite as your biopsy needle, not bigger than that. You introduce, and it is attached to a cylinder which is argon gas. And with argon gas, you introduce a lot of cooling gas which causes temperatures which go sub-zero and causes freezing of the entire tumor. And this is one such example. There is a patient, and I'll show you an example of something which you can relate. This is how the needle is tested, and you can start seeing the ice ball formation here when you are connected to the argon gas. Needle is introduced like that, and a freeze-thaw freeze cycle is started. If you can see here, in fact, the needle is started developing ice outside as well. You defrost it again so that the cell which was frozen and ice ball was formed within the cell. Again, now it gets melted and it starts expanding because of the water inside, breaks open the cell membrane, and again you start freezing it again, making sure that you re-cause the death of that tumor cell again. So beautiful examples. I think we are growing leaps and bounds in tumor therapies as well. And I just as the video ends, I show you the final outcome. This is how the tumor looked like to begin with. And if you see post-ablation, we have a huge ice ball causing the death of the entire tissue on the liver itself. Similarly, lungs and liver, similar results can be achieved. Obviously, you know, we've been known for doing a lot of vascular procedures, but simple things like placement of humans, mahukars, or chemocodes for doing long-term chemotherapies can be given under through vascular access. Sometimes if somebody has put a PICC line, it's broken, we can remove that as well. And I'll show you some of the other examples. These are all difficult cases where you have patients on CKD, and sometimes on dialysis you get swelling of the hands like that. Typically when you do imaging, you realize that the central veins are completely occluded, and what you need is high pressure balloon dilatation to make sure that the entire outflow from the fistula is still maintained, making sure that the dialysis continues being done on a regular basis. Typically when you talk of thoracic interventions, pulmonary embolism is one case where you have a huge role to play. Mind you, pulmonary embolism, the first line of therapy would be if anticoagulation to begin with, if the patient is hemodynamically stable, no bradycardia, no hypertension, RA-RB rate is not significant. You go ahead and do for a submassive or a moderate P, you do anticoagulation. But when you have a submassive or a massive P, which is causing hemodynamic instability, like in this patient, you have a large pulmonary embolism blocking on both sides. What we do is place a catheter from the femoral vein and directly do thrombolysis to that route. Typically, what we do is the activities of the thrombolytic agent is given directly to the pulmonary arteries and does not go systemically. And typically, these patients they might have acute DVT as well, which is causing the embolism to happen. Like in this patient, if you see on venogram, you realize an acute clot involving the entire external iliac vein. who do lysis typically now with the pharmacomagnetic or thrombectomy devices like in this patient with extensive thrombosis, what you can do is, in fact, a large protein thrombus within the IVC as well, and which had probably embolized and migrated. What we typically now do is place a filter, a removable filter, so that we can remove it, say, a couple of feet down the lane. And we go ahead and use these devices to clear up and remove the entire clot. Remember, these are done on table. At the end of 2 hours, the entire aggressive catheter is which successfully macerate the clot and remove the entire clot. You know, and by the end of the procedure, you do not shift the patient to ICU. These patients will be shifted directly to the wards. Like if you see the outcome here, there was no outflow, and now you achieve the entire outflow from the vein itself. Thanks. This is how it looks on the urine bag immediately post second day, but it does settle down. Sometimes you unmask the underlying vein runner syndrome. You do an IVUS and demonstrate that it's there with the intravascular ultrasound. You place a stent to make sure that the outflow is achieved. This is how the stent looks on IVUS post procedure, and you achieve the entire outflow from the vein. Now, talking of vascular emergencies on thorax, talking of hemoptysis. Now, you know the bronchial artery, I'm not going to go into the detail of that, but the first line of imaging would be a chest X-ray or a bronchoscope, sometimes CT. But if you find a highly hypertrophic bronchial vessels which is causing hemoptysis because of its connection to the tracheality, this is how you go ahead and do angiography and you demonstrate aneurysm, flush, and you embolize and stop the bleeding from the bronchial vessels. Sometimes you will have these bleedings from non-bronchial supplies like pulmonary artery aneurysms, and this is how we go ahead and close those with the help of a glue. Can you guess what is this? This patient had young female, presented with hemoptysis and an axillary swelling. This is the initial chest X-ray. Can anybody make a diagnosis on this? Anybody? Surfacing metastasis. This patient again did have some shadows here. Axillary node. This was diagnosed as COX. Patient was put on AKT. After 6 months post AKT, patient developed massive hemoptysis again. Massive hemoptysis, shifted to the emergency room, X-ray done. And if you see, this is the X-ray. Can you read the diagnosis now? Go ahead, sir. So, effusion mediastinal mass, again, scan was done, large aortic aneurysm, descending thoracic aortic aneurysm. This was, which was ruptured here and communicating with the bronchus and causing hemoptysis. Okay, this is how the aneurysm looks on angio. Again, no thoracotomy, we undergo, what we do is stent graft, endovascular to the femoral. We introduce a graft which is a stent covered by a fabricated PTFE coating, and you close the aneurysm this way. This is how we treat the aortic aneurysm in today's times. Things like this 6-year-old female presenting with cyanosis. Anybody can make a diagnosis here? Peripheral cyanosis, clubbing, breathlessness. I've given all the answers. No epistaxis, hemoglobin of 70. Can you see what is here? What is happening here? 2D was done. No ASD, no VSD device. No ASD, VSD happening here. Cyanosis, clubbing, breathlessness, hemoglobin of 70. So polycythemia. Any diagnosis? So here, when we did a CT, we found this multiple pulmonary AVMs in this patient. Typically, when you have a patient with possible telangiectasias, cyanosis, multiple AVMs, this is HHT, hereditary hemorrhagic telangiectasia, okay, HHT or Osler Weber syndrome. Typically, when you see these patients, saturation will be low. In this patient, saturation was 59 or 60% in that range. So what we do is, you will see these mucocutaneous AVMs happening either in the nose or the facial region. And when you do angios, you have pulmonary AVMs, artery and the venous shunting, you have hepatic AVMs, you have cerebral AVMs in this patient. What we do is, high flow AVMs, the way you close ASD and VSD, you go inside, close the shunt by placing the plugs like that, vascular devices. And if you see initially here, the pulmonary vasculature is not filling up, and post-embolization, now you see the peripheral pulmonary arteries. This patient's saturation not even improved from 59 to 100. Dramatic shift. This patient lived on 2 years down the line, develop a few more areas and get embolized further again. Any diagnosis here, unusual cause of chest pain. Diabetic CABG done 2 years back. I've given all the answers here. Blood pressure done, right hand 160 systolic, left hand 130 systolic. Chest pain is a patient who's undergone recent CABG couple of years back with a blood pressure difference in both the hands. I know Radha is working, he knows the answer, that's all. So, any diagnosis here? Where do you take the graphs for doing CABGs now? Lima, most of them, yes. Diagnosis done, left subclavian artery tight stenosis. Okay. How do you treat that? You go ahead and place subclavian stenting here, improve the inflow into the graft, and eventually the patient is taken care of. The chest pain medical. Last couple of examples I will show you. These days, yeah. So, couple of regional cases. Typically, these days you have patients with AKT on box getting treated, getting abscesses. Look at this patient. This patient had a cold abscess, treated multiple times by aspiration on the chest wall, but came with an emergency with severe bleeding. Can you make a diagnosis here? You can see the abscess area on the chest wall. You can't make out anything here, but you see some shadow in this region. Okay? Ultrasound that, and you have a cystic region with some sedimentation. Okay? Vascularity plus minus. We went ahead and did angiography, Mdmpa. Okay? This is internal mammary artery. Injected, and you can see communicating with the system. The huge aneurysm developing, communicating with the artery, it is eroding the vessel. Again, you keep on doing anything, it's not going to settle down. Again, go ahead, put some coils, block that aneurysm, and eventually this got settled down. Somebody kept on treating this as abscess, every time kept on aspirating, unfortunately, thinking that it will settle down by aspirating. Likewise, couple of other examples, huge area in the chest wall. These days, you have a lot of these young guys wanting to go to gym. I think this is one such example, excessive gymming, and at some point in time he had a tear in the muscle that probably he tried to get a massage done for that, and with that massage he eventually developed an AVM. He developed a huge muscle of that side, and he kept on feeling good that he's doing a good job by improving his vigor, and he's doing a lot of exercise. Unfortunately, because of the AVM, the entire biceps and the chest wall on that side kept on moving. He started worrying when he realized that it's developing only on one hand and one side of the chest wall, and he's not having any improvement on the other side. That's when he went, consulted a doctor, came to us, and on ultrasound we found a huge AVM. And if you see on chest X-ray, this is how typically the congestion is seen on one side of the chest wall versus the opposite side. And if you do the angio, usually hypertrophied subclavian artery branches, which is causing shunting, large AVM, which is already developed. This developed over a period of just 4 to 6 months, not more than that. And we embolized using plug and blue, and this is how a blue cast looks like that. And eventually we could completely stop the AVM, and blood supply was restored, and rest of the AVM completely embolized. Yeah. Last, I'll show you one case where lot of times you have patients with pleural effusions, and you keep on treating pleural effusions, looking at thinking it's a pox or it's some infection, you keep on getting it tapped again and again. This patient had a history of HCC, reflate. If you do ultrasound in this patient, we found out that this patient has chronic liver disease as well. Remember, we have a patient who's got chronic liver disease or cirrhosis and recurrent pleural effusions happening. They require tapping almost twice a week. This probably you are dealing with is recurrent hepatic hyperthorax. This is developing because of cirrhosis and not because of the pleural cause. This is how chest X-ray looked for this patient. Required tapping almost twice or thrice a week. What we ended up doing is we wanted to reduce portal hypertension in this patient. We ended up doing a shunt between hepatic vein and the portal vein and diverting the portal circulation. That's how reducing the portal pressure. And this is how the chest X-ray looked at the time of discharge and at 3 months. Completely cleared of effusion. this guy, there was no way you could settle down by keeping on capital regulars. Before I wind up again, just a reminder, we would require a lot of support from you for our Borivali Center. Thank you so much.
ऐसी तो हमारी तकदीर न थी आशा जो कोई टीचर मिले फिर आज खुशी से बात कर रहे हैं भावेश सर आपको I request Suri sir and the speaker and the secretary.
I usually highlight every time improving our knowledge. If our main idea is trying to your answer. Thank you.
Now I
the speaker.
Now I introduce Dr. Mdmpa and Dr. A. Jaiswal from the dais to illustrate our chairperson.
Very good. Thank you. Hello. And the prepare for the next very fast because they are late. Winners of Dr. Pradeep SS and Dr. Navkeet Pending. Dr. Pradeep SS and Dr. Navkeet Pending for the order. By इन्फेक्शन का सामान भी रहेगा
नाश में लगने की डायग्नोसिस की बसंत थी
ना सन्नाटा क्यों लगा है
Put your hands together for their view of Mdmpa.
जो सॉल्व करते हैं ट्रीटमेंट ऑफ इन्फेक्शन डिजीज का शाबाश डॉक्टर सिद्धांत and डॉक्टर यश
Now I would like to call for dais our chairperson for this session, Dr. Kush Pashnikar and Dr. Priyasudha Gurukar.
Dr. Kush is an Ayurvedic consultant practicing in Kurla for the last 5 years, and Dr. Priyasudha
She is MBBS from the prestigious State DS Medical College, Came Hospital, joined the public health department in 1990s. Has over 30 years of experience as health officer handling poor and needy patients at PMC Health dispensaries in Kurla, Bandra, and Dharavi. Welcome, ma'am.
I request the chairperson to please introduce the speakers.
Hello. Good afternoon, everyone. Today we have with us Dr. Yash Agrawal and Dr. Siddharth Shetty. Dr. Yash Agrawal, consultant physician and infectious disease specialist, visiting consultant at SL Raja Hospital, Mahim, Guru Nanak Hospital, Bandra, Oakard Hospital. He has fellowship in infectious disease at Pilgrim Hinduja Hospital. He had worked as senior resident medical officer at San Hospital, where he has conducted thorough patient assessments, diagnosing complex conditions, and initiating appropriate intervention. He has delivered empathetic patient care, addressing concerns, and providing support to patients and families during difficult times. Attachments at SL Raja Hospital, Oakard Hospital, KJ Somana Hospital, Lifecare Hospital, Sayan Prabhakari, and Rahul Nursing Home. Dr. Siddharth Shetty is MBBS MD Medicine from KM Hospital, ex-assistant professor at KM Hospital, Department of Medicine, CFID and FSP ID from Hinduja Hospital, Mahim, under the mentorship of Dr. Rajiv Soman and Dr. Aisha Sonawara, DTM and H UK, consultant general and infectious disease physician, TB, HIV, adult vaccination expert, OPD at Nirama Hospital, Nirama Health Clinic, Mahim, Sayan, Naval Hospital, attachments at SL Raja Hospital, Mahim, Sushruta Hospital, Dada, Guru Nanak Hospital, Bandra, KJ Somana Hospital, Sayan, and Rahul Nursing Home, Mahim. A warm welcome to you both, sir.
Be ready for the double entry.
Thank you. Thank you for joining.
Good afternoon, everyone. I am Dr. Sivan and Dr. Yash, and together we are we are a group of infectious specialists and general physicians based out of mind and science. And today we have a few interesting cases for you. I know I'm not going to do like it, but please bear with us.
We are back with our interesting cases this time. Our first case is umpire. So we all know what the umpires call and means in cricket, just what the people do. Let's see what this means in infectious disease. We had a 45-year-old female, healthy female, no comorbidity. She had a very short history of fever, dry cough, and sore throat, 3 to 4 days. She was symptomatically treated as viral illness, responded well to oral medications. A gene expert was sent unintentionally for this patient. Surprisingly, turned out to be positive. So we reevaluated her history. She didn't have any chronic B symptoms, no weight loss, no loss of appetite, never previously treated for TB. We sent a second gene expert, turned out to be positive for the second time. No immunosuppressive therapy and zero status was negative. With a CT chest, there were no parenchymal infiltrates and no lymphadenopathy. As we are suspecting, kuch to gadbad. So how do I go ahead with this patient? Should I treat her as TB? Or how do I convince her to take 6 months of AKT when she is now 100% asymptomatic? Should I observe this patient medically but she is sputum positive? So to understand this dilemma, let's go to the clinical staging of pulmonary tuberculosis. We have 4 stages depending on 4 parameters which are symptoms, radiology, microbiology, data. So latent TB, only IGRA is positive as you can see. In incipient TB, we have microbiological positivity. In subclinical, we have radiological evidence of TB, and in clinical TB, the patient is symptomatic. So before the patient actually comes to us with symptoms of tuberculosis, lots of things are going on in the background before the patient is actually symptomatic. This is how the natural progression of TB in our body. Once we acquire the infection, as we can see, some patients they can eliminate the infection all on their own. Mostly it goes into latency, and in infants it can cause primary tuberculosis. So it is a dynamic status of the based on the immunity of our body. It can vary in stages of incipient, subclinical, and active. So before the patient is actually symptomatic for tuberculosis, it can be in various stages, incipient and subclinical. So this patient is incipient TB, and beyond latent TB, any patient requires anti-tuberculosis therapy. In case the patient had come to us with this MTB detected trace and wave indeterminate. Any idea what do we do for this patient? Any clues? What is Gene Expert Ultra and what does this trace mean? Gene Expert Ultra is one step ahead of our Expert MTB ref. It detects insertion sequences apart from RPOBP. So the detection limit has gone down from 16 bacterial colony forming units compared to 114 of Expert MTB ref. Hence, when this Gene Expert Ultra detects insertion sequences and not RPOBP, we don't have a clear-cut idea whether if it is RIF sensitive or RIF resistant. Hence, it gives us RIF indeterminate. It does not mean resistant TB. It just states that we do not have an idea about rifampicin sensitivity. So, when do we treat this MTB trace? It is technically an umpire's call. So, this has to be treated in all extrapulmonary samples, CSF, ascitic fluid, in HIV positive immunosuppressed patients and pediatric patients.
We come to our next case. Watch what you eat. We're talking about much more than your waistline. So, this is the case we have treated at Raheja. This is a 45-year-old male who was a fitness trainer. He had no comorbidities. He had actually traveled to Malaysia, Kuala Lumpur and Langkawi in early July 2024. And he ate whatever he could find on the street. Okay, to give an accurate description, he had a lot of frog legs, very, very apathetic. So, Usab Khanetega comes back and 15 days later starts having abdominal pain, bloating and some semi-solid stools. And internet पे थोड़ा सा research करके he took 1 dose of albendazole for himself and a little bit of probiotics and he improved the timing. Again, this is part of the history of body later. A week later, presented with high rate fever and abdominal pain in the right upper quadrant, comes and gets admitted at regular. No history of loose stools. USG was done, followed by a CT, which showed this. You can see there are multiple well circumscribed lesions in the liver, which are liver abscesses. Multifocal liver abscesses. Okay. And also the abdomen CT showed cecal thickening. Okay. So now what are the differentials that we are thinking of? What kind of infection are we looking at if one wants to think of?
Cystic cirrhosis.
Not very typical for multifocal lens. They are single and or communicating. So, liver abscess in India, amoebiasis, gram-negative infection is most common. First, we got gram-negative infections like E. coli, Klebsiella, Salmonella, etc. Then parasitic. Is it amoebiasis? Is it any parasitic worm element? Are there gram-positive infections from the gut, like Enterococcus or Streptococcus? And in India, TB could present like anything, and there was some cecal thickening. So we were confused at this point. We started with we had high-grade fever, so from blood cultures. Okay, and first was aspirated, okay, USG guided, which was sent for cultures. And the cultures eventually came out to be low growth, and we started on empirically on Fishtas and Mdmpa. First was aspirated, sent for culture, it was empirically started on 50 days or Mdmpa. Cultures did not grow anything, despite having high-grade fever and a lot of phosphorus. And WBC was elevated, counts of 20,000, but eosinophil count was normal, so we are not looking at parasitic illness. And procalcitonin and CRP were very high. So now we are thinking towards a bacterial infection, most likely a gram-negative, like E. coli. And then colonoscopy for the cecal thickening was done, and this was what they found in the colon. Okay, very large, well circumscribed colonic ulcers, and a biopsy was taken. This is very atypical, this was not expected in any illness. So histopath showed neutrophilic inflammation, there was no granulomas, viral exclusion. Initially there was some response to antibiotics, but followed by worsening. And step up to high antibiotics, polymyxin B, antigen-cytokine, and metro was continued. And albendazole added to cover basically everything in that infection except B. We sent repeat blood cultures, OB negative and there was no response to the product therapy. So now what do we do? What is happening here? We have aspirated the pus, blood culture data, we don't have the answer. So here we were thinking that possibly there is some inflammatory fever due to the pus collection or due to inadequate source number. Basically, if you have pus anywhere in the body, unless you remove it, the fever will not go, how much of an antibiotic you take. And the last thing we are thinking is, are we missing any diagnosis here? So CT repeat, and we found that the abscess and HSI, we have become all cleared. Okay, the earlier circumcised abscesses. So we aspirated now again, we did about 60 cc aspiration. We rotated in blood culture water, we kept it for a long time in the lab, still we didn't get anything. Very good. TB gene export came negative, and now we were like, we have to find diagnosis. So we sent it for next generation sequencing, basically molecular genomic testing, along with whole genome sequencing. So next generation sequencing with a turnaround time of 24 hours came negative, whole genome takes around 2 weeks for the diagnosis to come, so we were awaiting it. And we thought fossil last definition of inflammatory fever, so had a little dose of naproxen and improved. So this is really happy ending. We did something, we gave all antibiotics possible, but we don't have a diagnosis. So 2 weeks of high rate antibiotics later, we started with oral cefixime, metronidazole and ceftriaxone to basically cover all our organisms. We gave it for another 2 weeks, and on repeat CT, the liver abscesses are almost gone. But still there was no diagnosis. Okay? And what was this? Okay, so this is something that we were not expecting. Finally, after 2 weeks, the whole genome sequencing report comes in, which shows this. Okay, so this is the parasite called as Pyromatra basically, it is the positive organism of something called as paragenosis. Okay, so microbiology में जब पढ़ा था parasitology, so this is one of those bugs which actually parasites which are native to animals. This is actually a parasite of cats and dogs. And then they release eggs into the water, and from water into cyclops. Cyclops are eaten by amphibians like fish and frogs. And then from froglets came into our host. Okay, so this was a very interesting case.
So this is part 2 of Watch What You Eat. We are doing this before lunch ताकि live थोड़ा सा हो जाए. 21-year-old male known with some ankylosing spondylitis. He was on treatment of methotrexate, enalapril, and NSAIDs. Never received any biologicals. He had some history of loose stools and abdominal pain. No history of fever. Initially, he stopped enalapril, very drug-induced diarrhea, no response, and then we gave some empiric antibiotics. Patient got better. Around 10 days later, now he developed left knee pain and left ankle pain. No issue of fever even at that point. We went ahead with an MRI followed by synovial fluid aspiration. This is MRI for left knee, which is showing some maloedema and synovial effusions. Aspirate showed around 33,000 cells with neutrophilic predominance. It is neither septic or inflammatory, somewhere in between. Started on patient on empiric antibiotics, no response, pain started worsening. What are the differential at this point? So we are thinking whether it is some ulcerative colitis. We started off with loose stools, followed by some inflammatory arthritis. So should we increase the immunosuppression, or whether it is some infective etiology, we should reduce the immunosuppression, start steroids. Went ahead with second synovial aspiration, cultures for no growth, gene experts were negative. Sent sample for next gen sequencing. Repeat synovial aspirate showed mild reduction in counts, which suggested that there is some partial response to antibiotics. And on next gen we got this organism, Bacillus cereus. Anyone wants to take a guess what this organism is? Any recollection? One hint for this organism. So basically it is known as Friedreich syndrome. This organism technically causes food poisoning from reheated Chinese food. हुआ कैसे? So when he took this history, he ate food at the wedding on the same day when he had the episode of loose stools. These organisms usually do not cause any septic arthritis or osteomyelitis, but whenever there is a damage or inflamed joint in the body, even transient bacteria, this organism has a tendency to get lodged in our joints. Hence, history is important for this patient. Patient was then started on IV vancomycin, given into and there was good clinical response. Some cases, any immunosuppressed patient, we should always rule out whether it is infective or inflammatory because of management depends on the diagnosis, increasing or reducing the immunosuppression, giving antibiotics. We should always suspect opportunistic infection in these patients because the typical ones likely to get diagnosed. It is the opportunistic ones which we usually miss out. And for diagnosing these opportunistic infections, our PCRs and next-gen sequencing are very helpful because they usually do not do our routine functions.
So this case is called the paradigm tragedy. So this is a 25-year-old male, this is a case from Hinduja in my training case. So he was an unmarried male from Ratnagiri. He had no serious medical comorbidities, did odd jobs for a living. Okay, and he had a particular thing about himself. Okay, had very high sexual behavior and had no significant travel history prior to the illness. So then he presented to us with fever for 5 days. Had jaundice for 3 to 4 days, breathlessness and desaturation for 1 day, and hemoptysis and oral ulcers with crusting for 1 day. So visited a doctor there in Ratnagiri, was given some medication, there was no relief, and some labs were advised, but he didn't do it. Again, remember this point, we'll come to this later. On examination, he was conscious, otherwise tachypneic, APY stable but desaturated. So started on O2, lots of palpitations, wheezing, BP, activate, and he had a lot of oral ulcers with crusting, as you can see in this. Okay, you can see the pharynx is very, very inflamed, and if you see the lower lip, you can see this bad crusting lesions. And this was the X-ray. It looked apparently normal, but it was test-wise very bad. Investigation just showed raised arms and all systems possible were affected: lung injury, kidney injury, mixed picture, liver injury, all systems. Okay, so what are we thinking? What would be the infected differentials anyone would want to contribute? Possible. We come to HIV later. But again, HIV causing so much of AKI, oral ulcers, not possible. Anything else? Here it's saying west coast of Maharashtra. Think of leptospirosis. Okay. Malaria, rickettsial disease. Again, is rickettsial common in this part? How many rickettsial disease do you treat or investigate? So if someone has attended our previous talk, even viral pneumonia like symptoms possible, and some rare infection like disseminated histoplasmosis, okay, and some non-infection differentials like rheumatological problems, etc. So for the history, we asked just to narrow down diagnosis. He was trained pesticide, but the contact when he had walked barefoot in the fields, there was no history of tick bite, and we did a head-to-toe examination, COVID tick bite to diagnose a rickettsial illness, and there was no history to case of bats for histoplasmosis. So started him on empiric doxycycline and azithromycin and sent all cultures and all the relevant investigations. So what are we found? Histoplasma antigen test urine negative, malaria negative, dengue negative, lepto negative, tropical PCR panel completely negative, and rapid malaria test negative. What are we thought everything? So now we will start. The urine protein also just shows signs of AKI and nothing else. Then we get a reference that the patient is HIV positive. But this may be not twist, it's not typically HIV positive. I'll just show you the report. Just take 10 seconds to analyze the report and tell me if the patient really HIV positive. So the first test is your ELISA, which is a screening test, 4th generation ELISA, which has come positive, which detects antibodies plus P24 antigen. And the second and the third test are the antibody tests, which are the confirmatory tests. So confirmatory tests are negative, and the first screening test is positive. So is this actually HIV infection? This can happen in two scenarios: in very early infections, or if it is false positive. Lot of 4th generation ELISA tests come false positive because of the sensitivity. Okay, like we saw in GeneXpert ultra trace. So we did an HIV viral report. HIV viral was negative. So we false positive HIV report found. It was not a positive report. So please check your HIV reports if they come positive, what test it was and why it came positive. Okay. So then we got patient is worsening, all functions are worsening again. We didn't have any answer, and you can see the X-ray is worsening. Okay. So after this we get a discriminatory. He tests positive RBC could explain everything. Scrub typhus. Okay. Scrub typhus IgM became positive. So now we had a partial diagnosis that it could explain almost everything except for one thing: the mouth ulcer. Scrub typhus means liver injury, yes. Lung injury, yes. Renal injury, yes. Bronchitis, tachypnea, and severe disease possible. But mouth ulcers cannot be explained. So anyway, empiric doxycycline and azithromycin was started. So chal raha. So at this point, we were struggling for a diagnosis, and that time the patient revealed some details to his brother. So chupke se bulaya that I
Last 2 months, sir.
The practitioner, and he had told at that time the practitioner knew the history of the patient, and he had seen the stress and clinical signs, and he had asked for an HIV test. And this was a Gaon educated boy. He had certain stigmas about the disease. He thought he may be having HIV. He consumed a pesticide. Okay, and this was all due to that. But he could not label what it was. It was not looking like OPC poisoning, obviously. So then he asked for a picture from the village, and turned out to be this. Anyone has any experience with dealing with this poisoning, called as paraquat poisoning? So anyone who's dealt in medicine knows that only one poisoning out of which the patient can ever recover from is paraquat poisoning. It has no antidote and it is the most severe toxin ever. And the point of discussing this case was that eventually succumbed. And the point to discuss was that despite having modern ART and HIV patients living normal, long, healthy lives, the fear of the disease and the stigma associated with the disease and improper counseling led to the death of the patient. And that is something to look at. We can have 2 more
Chikungunya is virus which is spread by Aedes aegypti, as we all know, with the same virus which spreads in dengue. So chikungunya, when infected in the body, causes viremia. It gets lodged in our joints, causing severe joint pains and fevers. Rarely it may have CNS presentation as well. This is important. Okay. So clinical presentation, as we all know, polyarthritis, rash, meningoencephalitis, cause chronic arthritis. So these are some clinical indicators. The patient will come with rash without any joint pains. So workup chikungunya positive is these formation.
So these are cases from Parliament scientifically where the patient post-chikungunya had developed deformation of skin and was very worried because chikungunya after taking it. So these are all residual changes. The previous case was actually painful technically and heavy, no joint pain, nothing, just fever and rash, blanching the nerves, and we did 3 dengue tests. And all 3 dengue tests are negative and chikungunya came positive and developed joint pain 1 month. We saw a lot of atypical presentation this time, and this is the chick sign. A lot of residual chikungunya patients developing discoloration of the nose as a retrospective diagnosis of chikungunya infection.
Two important points which are to be discussed: the diagnosis. Diagnosis in first 5 to 7 days is by PCR, and beyond 5 to 7 days is by IgM ELISA. IgM ELISA will be negative in the first week, and PCR will be negative in the second week. Mostly patients who come to us with fever, joint pains, they have one chikungunya IgM negative in the first week. Then to confirm in the second week of PCR is done, and both the reports are negative, and patient is left without a diagnosis. Second important point to discuss is the management. In the acute phase, in the viremic phase, we should use only and only NSAIDs, no steroids. Steroids are to be used after first 7 to 10 days, and beyond 3 months we can use DMARS. But the important consideration is this report.
So patient who had received steroids early on in the disease for arthritis eventually went into alternate sensory, again got transferred to Nigeria. All the bacterial tests of CSF were negative, and eventually CSF, PCR for chikungunya positive. He is going to be steroids early in the disease because it can get encephalitis, and this patient had to get IVIG and then get a slow gradual recovery, but very, very important.
I request the chairperson to please felicitate and thank the speaker.
I request Dr. Raghunath Gandhi and Dr. Mdmpa to come on the dais to felicitate our chairperson.
Just for the information of the crowd, in today's souvenir I have written one article on chikungunya. Please go through it, it's very informative and it will be helpful to you all.
सेंटर मध्ये
लकी ड्रॉ
सेंटर
शर्मा
and please refer patient to me.
Refer patients to me, they refer patients to them.
डॉक्टर अंसारी
Thank you.
डॉक्टर अंसारी माज
Please consider the chairpersons. Please collect your respective prices as you go on to the more lecture, go for lunch. जब lunch counter खुलेगा भी नहीं तो बाहर जाने की कोशिश भी मत करना.
इसने पी इसकी लाइफ हो गई इसकी
किस्मत खुल गई उसकी. शराब करे लेवर खराब, फिर ट्रांसप्लांट ही उसका जवाब. क्रिकेट में फेमस गांगुली सौरभ और लिवर ट्रांसप्लांट में हमारे प्यारे and I would like to call on the chairpersons for the session, Kunji Goyal sir and Dr. Poonam Mistry. I think I'm pronouncing it correctly, Mistry. Dr. Kunji Goyal is a former assistant dean at NEMG Sand Hospital, president-elect of Indian Association Mumbai branch, practicing dentistry in Sion and Dharam since last 40 years. And to accompany him, we have Dr. Poonam Mestri, practicing since 17 years in Santa Cruz, and recently she has started her assistant in practice also. She has done an MBA in healthcare and hospital care. She is a great OTC classical dancer. इसका कभी और प्रोग्राम रखेंगे ना. Over to you to introduce the speaker.
Thank you, Dr. Thank you for having the chairperson to us. I would like to introduce Dr. Poonam to introduce.
Hello, thank you for the beautiful introduction, sir. Talking about Dr. Gaurav Gupta, he's a leading liver transplant and hepatobiliary surgeon at SL Raheja Hospital, a Fortis Association Mumbai, with over 15 years of surgical experience, including more than a decade to liver transplant, accredited by the prestigious American Society of Transplant Surgeons, ASTS. Dr. Gupta is renowned for his excellence in liver and abdominal organ transplant surgeries, having performed over 500 successful liver transplants in Mumbai. He made history by performing the world's first combination liver, kidney, living donor transplant in Mumbai, a testament to his innovative approach and expertise. Dr. Gupta's specialties include laparoscopic donor nephrectomy, pediatric liver transplant, and pancreas transplants. His remarkable achievements and patient-centered care have made him the go-to choice for liver transplants in Mumbai. His topic for today is recent advances in liver transplant. Thanks, sir.
Thanks a lot. I'm sorry. So, I know I'm not going to try to finish my talk very quickly. So, we will talk about liver transplant. So, why it is very important, as sir says, you will see in the even in your practice, you will see more and more patients with the liver failure. And बेचारा risk तो claim करते हैं, but there are more patients right now which we see who are diabetes, hypertension, coming with fatty liver, and gradually developing liver failure. So you believe or not, 40 to 50% of my patients, they will say, sir, हमने life में कभी non-veg नहीं खाया, हमने कभी drink नहीं किया. But look at them, their BMI will be 35, their HbA1c will be 10, their cholesterol is 300. So they have all kinds of lifestyle disease, and which leads to cirrhosis and liver failure. Now people still only the diabetes will affect your heart or kidney, but liver is getting much. We see much more patients with liver failure with just NASH, which is called NASH, non-alcoholic steatohepatitis. So I'm just going to quickly start with transplant. Now, transplant is a relatively young field. The first transplant was done by this is Dr. Thomas Tazer. He is accredited for the first transplant in the world. Now, quickly, which are the patients, and if you come to them and you say, this patient for transplant. So, broadly, transplant indication is just only 3 indications. First, which is we call cirrhosis or chronic liver disease, both are same. 80 to 90% of the patients before transplant, they will be cirrhotic patients. 10% patient will be liver cancer patient or hepatocellular carcinoma patient. Another 10 will be acute liver failure patient. Now, acute liver failure, we will come to that a little bit later. Now, what is cirrhosis? Cirrhosis very commonly बात करते हैं. Now, cirrhosis actually it is a pathological diagnosis. Cirrhosis is irreversible. Important thing is irreversible, and the normal liver becomes nodular, shrunken, and hard. So this is how the cirrhotic liver looks. So this is how the normal liver looks, and this is the cirrhotic liver. When we take it out, explant the liver. So do you see the liver? There is nodules. So this is obviously grossly. Even in the pathology, you will see the nodules. Other thing which you will see the liver. Normal liver is very soft in palpate. This cirrhotic liver will be very hard. The size will be shrunken. It will shrunk. And other thing is, if you see the edges are very sharp. Here the edges will become rounded. So this is what is cirrhotic liver looks like. Now, thing is, any cirrhosis, if the cirrhosis develops, this patient will behave the same. And what are the causes of cirrhosis? these are the causes of cirrhosis. So just don't play with call. Hepatitis B, C, NASH. I keep telling you, this is the biggest killer right now. In next 10-15 years, more and more patients you will see NASH. This is the biggest epidemic right now. Other uncommon cause are autoimmune disease. Now, it doesn't matter what causes cirrhosis. Once the cirrhosis sets in, all these patients will behave same. चाहे उनको अल्कोहल हो, चाहे डायबिटिक हो, चाहे अल्सर्स हो, चाहे हेपेटाइटिस बी हो, चाहे हेपेटाइटिस सी हो, they all will behave like same. And how will they behave? So I'll tell you how they will behave. So these are the complications of cirrhosis which you will see. So they can present with ascites, repeated tapping करना पड़ रहा है. They come with repeated upper GI bleed. They will come with hepatic encephalopathy, ammonia level goes up, and then they will end up with encephalopathy. Liver failure can affect their creatinine. They can have acute kidney injury, jaundice. Obviously, all of them will have jaundice. Coagulopathy, one of the most important factor of liver injury is coagulopathy. You will see the patients coming to you with acute hepatitis B, C. हम लोग liver function test कराते हैं, SGOT, HGPT कराते हैं, thousands में आते हैं, we get scared. But actually, the one test which should scare you if a patient comes to you is INR. If the INR is high, coagulopathy is high, that is a patient that needs real care. SGOT, HGPT तो भर के वापस नीचे आनी है, but INR is the one test which you should do for each patient. Any liver patient should do INR. Other obviously sepsis and HCC. Now, I'll just spend one slide which is very important for, yes, this one. So if the patient comes to you and with a liver disease and को पहला सवाल होता है ये होता है सर हमारा लिवर कितना खराब है, कितने % खराब है, क्या हम दवाइयों से ठीक हो सकते हैं, क्या हमको ट्रांसप्लांट चाहिए, किसी डॉक्टर ने ट्रांसप्लांट बता दिया है, किसी ने बोला कि नहीं दवाइयों से ठीक हो जाएगा. तो which are the patients which should go for surgery and which are the patients which should be conservatively managed. So only thing is there are two scores. First score ये कर सकते हैं, मैं भी कैलकुलेट करता हूँ ऑनलाइन, इसका ऐप अवेलेबल है. It includes only 4 tests. पेशेंट का बिलोरुबिन चेक करो, पेशेंट का आयरन चेक करो, क्रिएटिनिन चेक करो और सीरम सोडियम. These 4 tests you put in the calculator, number will come. A normal person should have a score of 6. Any patient जिसका स्कोर 13 या 14 से ऊपर है, those are the patients that need a transplant. Simple test. So sodium, creatinine, iron, bilirubin. 4 tests. Google MBND स्कोर डालो, उसका रिपोर्ट आ जाएगा. अगर वो 12, 13, 14 से ऊपर है, those are the patients that need a transplant. मैक्सिमम स्कोर हो सकता है 40. 40 स्कोर का मतलब होता है अगर 100 पेशेंट्स हैं हमारे पास, तो 90% of them will not survive in 3 months. So they are there safe. 3 महीने के अंदर 90% mortality है with a MED score of 40. This is the old one which probably everyone knows. CTP हम सब लोगों ने पढ़ा है अपनी MBBS days में. So this is but it's still used, but MED score is much more commonly and it's much more scientific. CTP score आप खुद अपने क्लिनिक्स में कैलकुलेट कर सकते हो. अगेन वेरी सिंपल. आपने एंसेफेलोपैथी देखना है, पेशेंट को साइटिस है ये देखना है, एल्बुमिन लेवल चेक करना है. अगेन पीटी मींस आयनआर चेक करना है, बिलिरुबिन चेक करना है. ये 5 चीजें में से 3 ब्लड टेस्ट हैं, 2 क्लिनिकल टेस्ट हैं. एंड देन पुट देम 1 2 3 एंड दीस आर स्कोर्स व्हिच कम्स. अगर 5 से 6 है तो A, 7 से 9 है तो B, 10 से 15 है तो C. Now what is the significance? Again, अगर C है, those are the patients that should go for transplant. A है conservative managed. B है again they can be managed conservatively, but sometimes they might need to go for surgery. So these 2 tests will tell you अगर आपके पास कोई भी liver patient आता है, in which direction they need to go. So again, there's MED. I told you. So MED is very complex, but it's a calculator which are available. So I'm going to just skip a couple of slides for lack of. Now, important thing, but I want to tell each and every if you want to take home messages. Now, unfortunately, till now, कोई भी gene therapy, कोई भी therapy has not come till now कि आप cirrhotic liver को आप normal कर सकते हैं. Once the cirrhotic liver sets in and once
they have liver decompensation. Only cure for them is transplant. Now transplant आज से 15-20 साल पहले used to be considered transplant करेंगे तो patient बचेंगे ही नहीं, very expensive. But things have changed a lot in last 10-15 years in India. The results are very good. Even the cost is still little manageable. So that is the only therapy which can cure these patients. So this is our cirrhosis patient. So we talked about 3 indications: cirrhosis, CLD patient. Next is liver cancer. So HCC. Now HCC generally happens cirrhotic patients. Most of the HCC liver cancer happens in the cirrhotic patients. Now again, such patients gets initially referred to medical oncologist or surgical oncologist. Now any HCC, there are 3 therapies available. One is liver resection, second is immunotherapy and chemotherapy, third is transplant. All have their different roles. So I would not go into technical details. Some patient may need liver resection, some patient may need immunotherapy and chemotherapy, some patient may get benefit by the transplant. But among all these 3, if the patient fits into criteria, so not all liver cancer patients deserve the transplant, but if they fit into the criteria, transplant give them the best long-term survival. 5 years recurrence rate is less than 10%. Again, this is more technical key. Which are the criteria? These are the criteria. We don't need to remember these things. Again, these are some of the criteria for the transplant. Again, we don't need to remember. Just to see, these are how a cirrhotic patient, how the liver tumor looks. Now, in this patient, we have gone for a liver resection. We have cut the liver from here. These are the patient which, because he was not fitting into the criteria for the transplant. So, obviously, liver surgery is available. Okay, now this is very important. We started with कि अगर एक hepatitis का patient आता है हमारे पास, acute liver failure का patient आता है, तो what are the tests which we done? So again, as I told you, hepatitis, acute hepatitis A, acute hepatitis E का patient आता है. So there, everyone does SGOT, SGPT, everyone does bilirubin. But as I told you in the past, INR is the one test which you should do. अगर INR is more than 2, so those are the patients which you and even I am scared, because these are the patients which rapidly deteriorates. Now generally we don't do transplant till INR reaches 6 or 6.5. That is the criteria. But once it crosses 2, best is they should be managed in a hospital setting, in a setting where there is a liver ICU available, where liver transplant facilities are available. Common cause of liver failure, you know, rat oil poisoning, hepatitis A, E. Parastapol poisoning is very rare in India. AKT, now AKT therapy by week 2, week 3, anti-tubercular therapy can cause liver failure. So these are the patients which needs to be, as I said, any hepatitis patient, INR coagulopathy, very, very important. Okay, so just 5-10 minutes I will gonna take more. So how we discuss which are the patient we need is transplant. Now how to do the transplant? So there are only 2 ways you can do transplants. First is cadaver donors or brain dead donors, which all of us, not only medical community, even everyone in the society, we should pledge our organs to donate, because we pledge 1 organs, 1 patient can survive 8. You can give heart, you can give lungs. So those are the cadaver donation. Other is a living donor. So cadaver donation, ZTC is the organization which will help you in pledging the organs. You can pledge and you can even tell your near and dear ones, if something happens to me, so we should donate our organs, because they can survive, they can help in saving many lives. So rather than talking about donating our body, we should think about donating our organs. But one thing which I want to tell you, not all death we can take the organs, only the brain death. The brain death are the deaths which happen in the ICUs. So where the heart is still functioning, patient is on ventilator, but there is certain test which called apnea test we do. So this happens in the patient on stroke, head injury. These are the patients. They have a brain death, and those, if they are ready to donate the organs, we procure the organs and then distribute the among heart वाले को जाता है, lung को जाता है, kidneys 2 लोगों में distribute होती है, liver also sometimes हम लोग split करके 2 लोगों में लगाते हैं. So that's how the transplant happens. Now, couple of things about the living donor. Living donor, liver being a unique organ, it regenerates very fast. And then even if you take 50-60% of the liver, the rest of the liver goes back to almost 90% or 100% within time frame of 4 to 6 weeks. That makes us living donor liver transplant successful. Now, this is just a video. If I have time only, then I'm going to show you. You have time? 5 minutes. Okay. So this is how we do transplant. So once the liver comes out from the donor, so we split the liver into two halves, right side and left side. Right side the liver we take from the donor, and then we put into this special solution in the ice, so that liver is preserved. So we can preserve the liver for 6 to 8 hours. And then what we do is this is called benching. So there are vessels जो कि हमको connect करनी पड़ती हैं. So this is the part of the liver. Now we have to extend this vessel by these some of these synthetic grafts. So this is PTFE graft. So we connect this PTFE graft. I'm just gonna skip it. And once it is ready, then we put it into the, I think this is much more, so this is how we put the, so original cirrhotic liver is out. So there are two tubes working. Cirrhotic liver is out. This is the donor liver. It is ready now. It is goes into this our right upper quadrant. So just to tell you, so this is how, this is the head end. This is the, and this is in between is the inferior vena cava. So this is the inferior vena cava. So we will put a clamp. And when we join the hepatic veins to IVC. So this is the hepatic vein, which is, we do the anastomosis to IVC. So that is the first anastomosis. Second, this is the portal vein. So inflow has to happen. The blood flow comes to the portal vein, goes to the hepatic vein. So we did the outflow. This is the inflow. So we join the donor the portal vein to the recipient's portal vein. So this is the recipient portal vein, the recipient की portal vein है, this one, and this is the donor portal vein. So they will be joined together. And then, important thing I want to show you, just bear with me. So till this time, the liver has no blood flow. It is perfused with a special solution, and there is no blood flow in the liver. So, and then once the anastomosis is complete, then we take out the clamps and the blood flow will be maintained. So now, so this is the again portal vein clamp, this clamp, so you see, and you see the color change in the liver. The liver changes into the pink color. So blood flow is restored. Till this time, we put ice in the body because we have to keep the liver cool. And now what we're doing is putting the hot water because we need to bring the temperature of the body up. So this is again the hot water, so that the ice का जो ठंडा हो गया था body, so the temperature goes up. So this is called the reperfusion, and I'm gonna skip a couple of more slides. After that, we do the hepatic artery, which is very small. It is 2 millimeters. We do under loops, and then the bile duct. So I'm gonna skip this. So how? I can skip these things. I would want to have a little quiz, and this is not related to transplant. This is related to organ donation, which is very important, and which I think every one of us, whether you are a physician, whether you are a doctor or non-doctor, all of us should pledge to donate organs. So these are the scenarios. I just want to see how much even the medical community, I'm telling you, sir, are not aware which are the patients which can donate the organs. So there are just 5 quiz questions. So there is a patient has a heart attack. He expired at home 1 hour ago. हमको फोन आता है, सर हम organ donate करना चाहते हैं. Can you donate the organs?
Cornea and skin. Skin.
Okay. So let me clarify. Those are tissue. So cornea, skin, bones are considered tissue. So it's a tissue donation, not organ donation. Okay? So you cannot donate organs if you have a death at heart. Yes, very right. You can donate cornea, you can donate skin, bones can be donated, but these are called tissue donation. Okay? So they goes to the bank. So there is a bone bank, there is a eye bank. So वो tissue लेके they store in the bank and they can be transplanted later also. So this is a tissue donation, not organ donation. Important. Again, patient has stroke. He's in coma for last 1 month. Can we consider organ donation? Sorry, sir? Yes. So no, coma does not mean brain death. Very important. That will be illegal. That will be like killing a patient. Coma is not brain death. Totally different thing. अगर कोई F1 देखता है तो आपको पता होगा माइकल शुमाकर was in coma. He still has head injury. He cannot do, but he's not brain dead. So there's a different brain dead diagnose करने के लिए you need 2 neurologists, physician. Would they do a certain test? Then you diagnose brain death. Coma is not brain death. Very clear. Brain death patient is on ventilator. Coma patient cannot be on ventilator. Okay? So very important to remember. 5 scenarios. One more scenario. 80-year-old.
2 more minutes, sir.
Yes, please. Had stroke, admitted to hospital. Now here, doctor himself is saying his brain is not responding, probably brain death. Can 80-year-old donate organs?
No.
So yes, I'll tell you. There is no cutoff for organ donation. Okay? I personally have transplanted a patient, 88-year-old donor. So especially for the liver के लिए there is no cutoff. Kidneys, sometimes as you age, आपके अंदर उसमें sclerosis, fibrosis आता है. So sometimes 80, but even 80-year-old, if the creatinine is good, they do a frozen biopsy, they can use. So age is not a cutoff for organ donation. Okay, very important. So patient has fall from railway, suffered severe brain injury, admitted hospital. Doctors are telling he's brain dead. Social worker from hospital come and give us option of organ donation. But हमको लग रहा है उसकी तो heart चल रहा है. We can see the pulse, we can see the BP. How come the doctors are telling he's dead? So as we discussed, brain death is a legal form of death. Legal form of death. So yes, if they have tested and they know he's brain dead, so I just want to explain you another. So हम लोग organ retrieve कैसे करते हैं? Once हमने diagnose कर दिया he's brain dead, relatives ने signature दे दिया yes they can take the organs. Now this patient will be taken to the OT, okay? Just like any other patient. We operate just like any other. He is on ventilator, anesthesia is on. We operate, we open the chest, we open the abdomen. सब लोग assess करते हैं. Heart की team heart assess करती है, liver की team liver assess करती है, kidney की team kidney assess करती है. And then once everyone is ready, then we clamp the aorta. Okay? That is the time when they remove the stop the ventilation, and then we perfuse the organs with a special solution. Put the ice, heart team take the heart, put them ice, liver team take the liver, kidney team take the pancreas team take the. That is how the organ. So till that time they are treated just like any other sick ICU patient. Unka BP monitoring, unka sodium monitoring, everything is done. Till that time they go into the operation theater, and then till we make a incision. So that's how organ donation is done. There's one more to follow. Okay. Last. So patient is in ICU, ventilator support, no cornea. So these are important. Brain dead patient has no reflexes. His temperature is 32. Again, if you know, can we proceed the apnea test? Apnea test, actually we forgot to we have not discussed. Apnea test is a test which is a diagnosis from the brain death. So apnea test में हम लोग क्या करते हैं? पेशेंट का एक बेसलाइन एवीजी करते हैं, उसका वेंटिलेटर से डिस्कनेक्ट करके उसका O2 डाल देते हैं थ्रू द ET ट्यूब, एंड देन आफ्टर 6 मिनट्स 8 मिनट्स वी डू ए एवीजी. अगर कार्बन डाइऑक्साइड लेवल इज मोर देन 20 राइज फ्रॉम द बेसलाइन, दैट इज कंसिडर्ड पॉजिटिव एपनिया टेस्ट. ओके, सो अगेन दिस इज टेक्निकल. अगर द एपनिया टेस्ट इज अ डायग्नोसिस फॉर ब्रेन डेथ, Apnea test generally we don't do if the temperature is very low. So we bring the temperature up and do the apnea test. So I'll finish the talk. This is just my team, and so we had started transplanting at Raheja also. And I thank you for listening to the talk.
Thank you very much, sir. It was very informative information about organ transplant and organ donation also. और सर ने एक बात कही है कि liver failure is not because of your lure for alcohol. तो महंगी हो या सस्ती थोड़ी थोड़ी पिया करो.
Now I request Dr. Singnapurkar sir, please come on the stage to felicitate the speaker. Now I request Dr. Bharti Desai and Dr. Santosh Jujar to come on the dais to felicitate our chairperson.
Satish, Cooper.
So it was a very good lecture.
हेलो हेलो माल करते हो आप हेलो एक्स्ट्रा एक्स्ट्रा लगा के देते हैं हेलो 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 एक्स्ट्रा लगा के देते हैं ये माइकल
हेलो
एक्स्ट्रा लगा के देगा क्या पहले
लकी ड्रॉ विनर डॉक्टर अयस फारूकी